activities of daily living and so on. So that's practically it. So before we delve in, I don't know, I saw Destiny Amarachi. I saw your hand up, but now I was hoping to get to call you when I am done talking. So are you still, did you have something to say?
No,
Destiny?
no,
Okay, so let's ride on. Let's ride on. So when we started this training, from the time we started the training, we've been looking at some modules. We had a couple of modules, about 15 of them. We've looked at introduction to healthcare, ethics and professionalism, anatomy, physiology, infection control, patient care skills, vital signs monitoring, assisting with activities of daily living, safety and emergency procedures. So today we are going to look at the next 4 modules, which is communication, medical terminologies, care planning and documentation, end of life care. Like most of the things in this particular module is theoretical. So that's why we'll just get to it as it should be. We wouldn't spend too much of time. God willing, by 7 or 7 something thereabout, we should be out of here so we can get back to our different businesses. But before I continue, please, I'd like to ask on the platform, I'd just like us to maybe share 1 or 2 things that we have learned, or maybe if we have any other response, if you have something you didn't say, because I observed that some people were actually passive after watching that video, perhaps in their minds, can I even take this kind of thing? Is it really and so on? I know some people may have those questions in their minds. As soon as I saw that video, I just assumed that some people would say, why am I even here? You know, so I don't know. Do we have does anyone that did not comment, do you have anything to say? Or do you have so far, what has really stood out for you? Just maybe a lady and a male, and then we walk right into what we have for this evening. So who is going to build the cards? And I'm just thinking, I don't know if I have heard, if I'm wrong, I stand corrected. Susan, I'd love to hear your beautiful voice. Can you just say a sentence in something that you have maybe got learned in the course of this training? Just something. Just maybe something you didn't know before, even you knew. Is she here? Susan?
Yes, ma'am, yeah.
Okay. Susan, I love to hear your voice. So can you talk so I can hear your voice? Thank you.
Okay, ma'am. What I've learned so far is before you can go into satisfying nursing assistants, you have to be passionate about the job.
Okay. Thank
passionate
you.
And at the back of your mind that you are going there to take care of people that are vulnerable, health-wise, that really need your assistance. So they need your love and care while taking care of them. And there's something that you need to overlook in the course of taking care of the patients.
Thank you. Thank you so very much, Susan. I just needed to hear your voice because I'm just, that's so nice of you to give us that response. Beautiful. So, do we have, okay, Hope Nwachi, you raised your hand. Okay, Hope, you can go ahead.
Good evening.
I knew you were going to ask a question because I saw what you wrote on the platform. Go ahead and ask or say what you want to say.
Yes,
all right,
I learned a lot, though you just say 2 days class, and I've learned a lot, most especially the videos that you sent in that slide. I was looking at them today. The manner of approach is very, very crucial and important when you are dealing with, most especially, people with dementia aspects. When I was watching the first video, the woman and the man, in fact, and the terminology, the way the manner of the satisfying us we are using, most especially the hand finger hand they were using hair. That was what I said, wow, this is another strategy you can use to grab a patient, most especially those one that have those kind of irritable behavior. So manner of approach, very, very important, which I've learned, most especially on that video aspect. Taught me a lot of things. To use the mind. Some patient here I have. Thank you.
Beautiful. You're welcome, Hope. Thank you for that comment. You see, like I like to do my trainings, I like to mix it up, to spice it up. So even when I talk, I still need you to play the visuals and then just see how to go about it. Thank you so much. Okay, please, can a man just build the cards for the men? Who is going to build, who is going to help us? Just a man. Let it not be a women's affair, you know? Is there any man that wishes to say something?
Okay, ma. Good evening once again, ma.
Good evening, Mr.
Please, I want to ask question. This question might not really, go along with what we are saying. But
Okay.
this particular thing that always strikes my mind all the time.
Mhm.
I was opportuned to work in an hospital, in the federal hospital, sir, to be
Okay.
precise.
Mm.
So I used to notice a lot of things on the ward, you know, looking at the way the nurses are dealing with the patients, our so-called healthcare assistants too, the way they deal with those patients, I can see that, all what we are taught here, maybe they are not applying or something. I think, so I just want to know what is really wrong in this our country called Nigeria. So does that mean that they don't know about all these things or what?
Okay, thank you, Mr.
Yeah, good
Michael.
question.
I just had to laugh a little bit when you said this, you know. See, there's a song that, like I told you, that I like to teach, and I teach a lot. So there's a song that they used to sing, that we used to sing, or I used to sing with my a long time ago when I was still teaching. They used to say that, you in your own corner and I in mine. If I shine in my corner and you shine in yours, we'll have light, enough light that will be able to illuminate the room. So why am I saying so? There's actually a challenge. What you have said, Mr. Michael, is very correct. Not only in Nigeria, it happens anywhere, because when we keep saying Nigeria, it can happen anywhere. What you have said are things that I have seen also. But that is why there is a difference between one having the right knowledge and one having the right knowledge and one not having the right knowledge. They are two different things. You understand? So please, regardless of what we see in the health field in our journey, we should stand out. Because true to what you are saying, I myself, I have observed these things. I have seen them live. It's not as if we are just saying it. That's why a couple of us, we just had to burst into laughter on this platform, because it's really true. That is what is obtainable. But the fact is that since you have this knowledge now, Mr. Michael, and I have mine, I will shine in my own corner. Susan will do hers. Mr. and Mrs. Wisdom will do theirs, as well as every other person on this platform, Hope and the others, on the platform. If they have the right knowledge in wherever they'll find themselves as certified nurse assistant, they will try in their own capacity to follow the knowledge that they have learned, do the best they can, and the world continues to go around. That is it. Because some of these people, they don't know the essence why they are in the health field. That's just the truth of the matter. That is why when I started this training, I took time. It wouldn't have, I presume it didn't seem as if I was talking too much. No, I like to do it anytime, because I try to disabuse your minds of anything, all those things. I try to ensure that you are on the right path mentally. That's your thoughts should connect with your behavior, with your attitude. When you eventually go there, everything should link up. That's why we are having this training, because you can see others behave, and you can gently, and you can also share the knowledge you have with them. Let them know that when a person is ill, the way you treat that person, it matters. It can go a long way. CNA plays a very crucial role in the life of a person, of a vulnerable person or an ill person. So in the setting, wherever you find yourself, like I started by saying that song, you in your own corner and I in mine, is a song. That's if you do your own, as we are on this platform, about 30-something people, wherever we are, we try with the knowledge we have, we do our own. The more we keep enlightening people in other platforms too, with the knowledge that those ones have been able to gather, gradually, we begin to erase the system of all these anomalies, all these things that you have talked about. It's not really about Nigeria. Like it's not a Nigerian tag thing. It just happens in some places. Though, like I like to say, when you go out, maybe abroad to other countries like that, highly developed countries, you will not bring all those things there because you can get on the other side of the law. Any little thing you do with that, that's why CNAs are advised that you only do the things that are within your own training knowledge, your own limits to do. Someone shouldn't ask you to do something that you don't have the right training to do. You say, okay, because I've been seeing it done. Yes, I've seen the other person do it. I've seen the doctor do it. I've seen the nurse. I know how to do it, and you move and do it. Then it happens. Nobody will say that. So that's important. Mr. Michael, I understand how you feel, but
Please,
the
I'll
fact
call you
is
back.
that
I'll call you back.
when we do what we
I'm
can
in
do
Zoom. I'll
on
call you
our
back.
own, we are not actually responsible for what anybody does. The only thing we can do is just to tell them, give them the right knowledge and try to tell them, but we have an extent, and you also have the duty to report. So even when you work in such settings and you see certain things that are abnormal, that shouldn't be done in the proper way that it is done, you have the right to report. And you may have a challenge if the person you want to report to, for example, maybe is the registered nurse, and the registered nurse, which is your boss per se, your immediate boss that you have to report directly to, is actually the one that is carrying out these anomalies. It happens in some places. It happens in some settings, though not everywhere. So you become faced with a challenge. So these are some of those things that you're bound to see. But the bottom line is that you do what you know how to do best and what you have to do at any point in time. That is the beauty of it all. So, Mr. Michael, I hope that have answered you. Okay, so let's quickly delve into what we have. We're talking about communication this week. We are going to look at the welcome, Mr. Michael. So we are going to be looking at communication skills. Like I would like to say, communication is a very, very important aspect of our lives. We said something in the passing last time concerning this. Now, the whole duty of a CNA is intertwined. That's, you can see this one can link to the other. You can see it can link to, there are major things that you cannot avoid, like communication. It cuts across vital signs. It cuts across most of the things that are considered your duties. And very importantly, as a CNA, like I always like to say, one of the most challenging aspects of your nursing assistant's duty is the high demand for communication with those around you. Is very important, because by virtue of the fact that you are like a middleman, permit me to use that word, like you are in between the registered nurse and the patient. You are also a member of the healthcare team, and you are the closest to the patient. So everybody wants to get first-hand information of what you observed in the course of you doing your ADLS, that's your activities of daily living. So it is very, very important that as a CNA, you must have a top-notch form of communication skills. You must be able to communicate with people. You don't get angry. Put up a friendly disposition, an amiable disposition. Put on smiles. I don't mean you just smile anyhow, sheepishly. No, I mean that at least don't frown, because candidly, I've seen situations whereby your body, we are going to get to body language, your body language of even your non-verbal expressions of you even frowning your face can be like a put off to the patient. Yes, I've had situations whereby, yes, I'm going to thank you for reminding me, because I was busy engrossed in the talk. So let's move. Good. So thank you for that. I was busy talking. Patience gold. Okay, thank you for reminding me. So, as I was saying, it's very, very important that we use proper body languages. We learn to talk to people. We have the right communication skills, because the major thing that we'll do is communication. One of the major duties of a certified nurse assistant is communication, because you'll be asked, okay, how did this person you communicate? Oh, when I was taking the patient to the toilet, I observed she was this. For toileting, I observed this, I observed that. You are the one that does a lot of talking. So it is important that you talk. And also you maintain, we've talked about slouching. Now, what do we mean by slouching? If you see on the second bullet point, slouching simply means for you to learn as a certified nurse assistant, not only even a nurse, anybody in the health field, it's advised that you have a correct posture. You have the correct standing posture and the correct sitting posture. So when you tend to have a posture that makes you to maybe stand or sit or walk with the shoulders hanging forward and your head bent slightly so that you look tired. Non-verbal expression, we'll get to that. You look tired. So at any point in time, make sure that you have this kind of agility around you as a certified assistant. You have to be agile. And that's why you have to be on top of your game. You have to take care of yourself, because if you don't take care of yourself, you cannot be agile, like this agility we are talking about. You have to look confident. You have to look relaxed. You have to look friendly, like that video that Hope just talked about, like we all have in that slide. If you see that, look at it, confidence. Confidence comes from you knowing exactly what you want to do. If you don't know what you want to do, there is no way you'll be confident. That's what I tell people. Maybe you don't actually understand a particular thing, or you have a presentation and you have not memorized your lines, or you don't know you have to act a movie and you don't have your lines, that confidence automatically leaves you, because confidence is embedded in the fact that you are on top of your game. You know what you want to do. So that's one of the things. So as a certified nurse assistant, confidence is important. You look relaxed. And then it's equally important that when you talk to people, I'm just trying to give it a rush because we have a video, like I like to do. We have a video that will take time. I would advise everyone, I'll tell you to sit down relaxed. Look for a chair if you are standing, or look for somewhere relaxed. The video is going to teach you a whole lot of things. And after that video, we are going to discuss it. So I would really want everybody to have a clear view of that video, because most of the skills that you need as a certified nurse assistant is summarized in that video. And then you just pay attention and look at it. But I have to give you an introduction and talk about it a little, as I like to do. So eye contact is very important. It is important that you talk with people and you maintain eye contact. For example, in maybe to your boss, and your boss is talking to you, and maybe you are looking elsewhere, or you are looking, like initially, I had a student that maybe whenever I want to pass an instruction, a grown-up person, anytime I want to pass an instruction or to tell her something, not in the hospital setting anyway, she's on her phone. She's on her phone. It also happened with my teenage children. When you are talking, can you help me get this? Yes, mommy, they are answering you and they are on the phone. They are not even looking at you, like to understand what you are talking about, listening to you. They're engrossed in another thing. So one way that you can actually show respect, or you can actually show someone that you are interested in what that person is saying, is for you having eye contact. Again, I want to let you know something, like we talked about how best you can handle your client, depending on your patient's preferences. Now, there are certain situations, certain cultural beliefs that we have, that you talking to a younger person and the person looking you directly in the eye, it looks like an insult, like I like to tell people. So that is why it is important that you know your clients, like you know the person you are dealing with, you know an extent of that person's cultural beliefs, you know what that person considers right as an insult or not. Isn't it this particular communication skill cuts across everything we do in all facets of life? It cuts across it. Communication is very, very important in our lives. So, but for the practical aspect of you attending to a client, you have to ensure that you look the client, eye contact, because you know why? Because when you are looking at someone, it's difficult to forget. I want to give you, like when my teacher, so many years ago, I want to tell you the impact of eye contact. So many years ago in my primary school, secondary school, I was taught Pythagoras theorem. I was taught that. As at that time in mathematics, Pythagoras theorem. I was taught that. And when the teacher was teaching, I was looking at the teacher, like there was eye contact, direct. I was so interested in the lesson and I was looking at the teacher. And I can tell you that after so many years, after a whole lot of years from that time, even as I'm talking to you now, I can still visualize my teacher teaching me that Pythagoras theorem. So why am I bringing that illustration? When someone talks to you and you are actively involved in what that person is saying, you maintain force can relate to that. So when you are relating with your clients, and remember they are vulnerable people, your attitude matters, your non-verbal expression matters, the way you do matters, the physiognomy of your face matters. Are you frowning your face? Is your face in a contorted form, or you are angry at the instruction they are asking you to do? Yes, it happens in It happens in hospitals and so many places, you know, where you see, even you as a visiting, maybe you just visited your family member that is in the hospital that is not feeling well. You see the way, like Mr. Michael said, you see the way some of them behave. Maybe if there's water on the floor, there's something, they say, just come and help us, or we need this, or we need that. And the next thing, you see it on the physiognomy of their faces, the face of the person, that he or she is not happy, but there's nothing I can do. Grudgingly, reluctantly, the person has to do what you want to be done. So listening too, active listening is very important, where you can convey your understanding by repeating key points. I had already said this, I think, on this platform, if I am not wrong, some time ago, that when someone tells you something, you repeat it. Key points back. Oh, did you say I should get you a cup of water? You understand? Or what were you trying to say? So that the person can say, okay, I was trying to say that I would need a cup of water. So now you have now emphasized, you heard him saying something like that, but you needed emphasis so that you actually know what to go and get from from where you should get it, a cup of water. So listening is how you can build trust. When you have these people, you know you have to connect with them. Connection cannot be taken out of the healthcare game. It can never. If you don't connect with a person, you can never attend to that person's needs. That's just the truth of the matter. Not only as a vulnerable person, but even as your children, maybe those of us that have children or family members, those that are married with husbands, or if you don't connect, if you don't build that connection, there is no way you'll be able to attend to the needs of that person. It is just a normal, a natural thing. Even in the workplace, if you don't connect, as a teacher, you don't connect with your students, tell me how you are going to impact that knowledge in them. It doesn't happen anywhere. As a family member, you have a child, you don't connect with that child. You don't spend time with that child. You don't give the child an atmosphere where the child will be able to relate with you, tell you what his or her challenges are as a mother. You find out that because there is no connection, that child now takes solace in the hands of other people. And before you know it, it is medicine after death. It's too late. So these are some of the things that we really need connection. And how can you connect? Actively listening. Someone is telling, your patient is telling you, oh, I'm feeling this or this, I couldn't sleep throughout the night, and you say, oh, you couldn't sleep, what's even my own business? I remember one particular lady some years ago had said that into my hearing when I took my niece to the hospital. You know, she was in labor, so we went to the hospital. I went with her. I was practically there with her, but one of the healthcare workers, they made a statement. Understand? One of the healthcare workers made a statement saying that, I don't know, there was actually something. Then she said, does that put food on my table? Like she was, I don't know, I'm trying to remember what was the exact word, but she said, does that put food on my table? That is what the patient was like trying to say to her, was like, it doesn't have anything to do, it has no advantage. So does it put food on my table? Of course not. So it's not my business. So these are some of the things that we should try to see how to do away with. Another thing is not interrupting people, not interrupting others. This is very, very important. I had to ensure that this skill, I try to ensure that it stayed in the lives of some people that I actually had dealings with, because when you talk to people and when someone is talking to you, it shows respect when you listen to the person. When you listen to the person, finish talking before you actually interrupt the person. Not only in communication as a patient and a certified nurse assistant, it could also go in any other aspect of our lives. When someone is talking, maybe a father is talking to a daughter, a child is talking to, or a doctor is talking to a nurse, or a nurse is talking to you as a certified nurse assistant, or vice versa, they should listen without interrupting. Let the person land. That's the word. That's the layman's word. Let the person land. Sometimes you hear people, you talk to someone, and the person will say, please, can you just allow me land? Allow the person to talk. So that when the person lands, you now get a grip of what the person is actually saying. Then you can then say your own. It's more honorable to listen than to talk anyway. So you see that you have to listen. So it's very, very important. I had a friend, like I like to tell you, I have a friend that calls me. When she calls me, she'll just go straight to the point. Oh, Mrs. Dorothy, Dr. Dorothy, I want you to get this for me. I want this. Do you remember that thing that we did? Okay, I've heard it. Before you know, she has cut the call. Even when you are talking, you say, okay, I've heard, I understand what you're saying. Before you know, you call the call. So she has been doing that for some time until one day I had to put out. I told her that it's not right, that when you cut a call on someone or you interrupt someone when the person is talking, it is disrespectful. Doesn't show that you know what you are doing. So please, let's just be on the same page. And thank God it has actually paid off. So it is important that you listen. Resist that temptation, because it's actually tempting for you to try to cut into the conversation. Maybe the person is trying to say something that you didn't do, or the person is trying to, talk. You should allow the person learn. When the person learns now, you now put together your own and then get to it. So, like I like to ask, please, are we together? Or I'm just doing a lot of talking. So let me move. Are we together, please? Can you hear me?
Yes, ma.
Yes, ma.
Okay.
Yes, ma.
Okay, thank you. I think only 3 people can hear me. It's fine. Okay. So let's get to
We can hear you.
the next one,
Please go ahead.
patience. Okay, thank
We
you.
can hear
So
you
patience is
very
another
well, loud
skill
and clear.
that we
Yes, ma.
thank you. All right, thank you everyone. So patience is another skill that we need to. Patience, to be patient. I'm just trying to rush it through because we'll get to watch the video. It's important for us to be patient with our clients. Follow them gently. It's like those of us that have parents that are elderly, that have maybe relatives that are elderly. You really need patience with them. Even if you are not a healthcare worker on a very fine day, you need to be patient with them because they take time to talk. Do not rush do not rush talking to them. Do not rush following them. Take it easy with them. Maybe you want to take them for toileting, you go slowly, like we had that video. You want to, whatever you want to do with them, you understand that they need to. And there are some people that might be poor communicators. They have a hard time getting a point across. There are some people like that. It's an innate thing. Maybe they find it difficult. They struggle with how to put together pieces, bits and pieces to actually make a point to be able to get across. Because of this, you need to exercise additional patience with them when you are working with them. Very important. People that are maybe they have a speech a challenge, maybe it takes them time to form words, and a whole lot. These are things you need to consider. You don't rush and say, oh, I just have to be, I have other people to attend to. Of course, I cannot be here. I don't have that time, So these are things that we shouldn't. Granting a person undivided attention also before responding to a comment can show that you are truly listening. So patience is very important. Maintain positivity. This is, let's see, I think we still have, all right, we still have one before we get to the video. So maintaining positivity is very important in this, our line of business as certified nurse assistants, in the healthcare business, in the business of serving humanity and saving lives. You have to be positive. Sometimes you see a situation that is not even that, as if all hope is lost. It's advised that you maintain a positive spirit. I don't know, we may not all be Christians, but whether we are Christians or whether we are Muslims, we all believe in a supreme being. We all have we all have laws that are interwoven. That be you Muslim, be it you Christian, we still have our spiritual values. So aside the spiritual values, it's just a mindset of positivity is very good. A merry heart is just like medicine, does good like medicine. Like we like to, there's a song too that's like that. A merry heart does good like medicine. So it's good for you to be happy because you are dealing with people. It's good for you to maintain that positive outlook. No matter what the situation looks like, you shouldn't be upbeat. You shouldn't be, moody. You shouldn't be difficult to approach. No. No matter the situation, always see the positive aspect of it. Always see the good in everything. Like I tell people, always see the good in everyone, in everybody that you have any dealings with. Always see the good. Yes, wisdom is profitable to direct. Seeing the good doesn't mean that you should cross boundaries. No, but it means that you should see that that person has something good in the midst of all those things that is happening. The person still has something good. So these are some of the things. So even as a certified nurse assistant with a patient that you get to see every time, you should have this connection, maintain positivity, even if it is hospice patients. When we get to hospice, you understand what I'm saying? Even if it's a patient in that state that has maybe terminal illness, that has countdown to some days to go, that's the more reason you have to be positive. You have to maintain a happy disposition so that you will help that person in that particular trying moment of a person's life. Then dealing with patients too and healthcare professionals, you have to talk a lot, like I said. You have to do a lot of conversations with them. Try to remember that if you get angry or upset, hey, it doesn't show that you're professional. I have seen situations whereby nurses maybe have to shout, or certified nurse assistants, or healthcare workers, or healthcare aides, healthcare assistants, people in the healthcare setting, they have to shout, they have to maybe just show some form of attitude. It happens. We've been having experiences which I would love people to share if we have the time. You know, you just share the experiences so that you get to see how it felt on you. So you can then interchange the coin, turn the other side of the coin, and place it that if that person was to be there and you were doing like that, how would you feel? The person, of course, will feel the way you felt. So that is just it. Try not to let your emotions cloud your judgments. Cloud your judgments, your sense of maybe reasoning or your judgment. Do not allow your emotions to cloud it at every point in time. It should not affect your ability to communicate and do your work. Like I tell people, especially women, we understand. Women easily show emotions. So when there are things like that, you try to put them. Maybe you had issues. Maybe you had some form of aggression or aggressive encounter somewhere. You shouldn't transfer it to your patients. You should not control your emotion. Emotional, I'm trying to remember that word. So you should know how to control your feelings. You understand, at any point in time. Do not transfer it. Maybe you, thank you so very much. It just jumped out of my head. That is just the way it happens sometimes. So emotional intelligence, thank you so very much. Who gave me the meaning to that, Seth? Who is the person that just gave me, that just reminded me?
Nena.
Okay, Nena. Thank you, Nena. That's so nice of you. So emotional intelligence is key to anything that you do. Aside in the healthcare, everything about you contained with it. Don't and would not have to revolve around us or one person or me. Other, it's not all about you. You have to, the world doesn't, it's not all about you, you, I, me, I mean, yourself, everything, myself, I, and me. No, it has to. You should think of other people's emotions too. So at this point now, like I said, I want us to watch this video, and this video is actually 15 minutes. That's why I say get a position that is comfortable for you. Sit down. It's going to show you a whole lot of things. It's going to teach you everything about communication, and it would go a long way in helping you in your duties. So I'd like to do, I'd like to find out if we are actually together. And then if you can hear the volume, please let me know, because, you know, technology is another thing. So I need to know if we can.
Yes, ma'am.
Yes.
Okay, so let me know if you can.
The information to understand communication. Use communication skills to interact.
All right, so what can you say about the volume?
The volume is too low.
It's very low.
Can you hear?
The volume and the video is cracking.
Yeah, and it's breaking.
Hello?
Yeah.
It's breaking. The video is breaking. We're not hearing it clearly.
People. You will have the information needed to understand.
Video, me, I don't understand what network is doing.
Interact with families.
Okay, please hold on. Just hold on. Just hold on and let's see. Okay.
May influence behavior. Recognize and respect differences among people.
Any
in your care.
volume?
When you knock on Rachel Morgan's
it's okay,
door.
ma'am.
Hello?
This one is
Okay now.
better.
Okay,
Okay,
ma.
Better. It's a bit better.
please try. If you have earpiece. Yes, I've increased the volume. So the volume is just It's just perfect. If you have an earpiece or something, you can use it to help you better. So I'm just going to start it and let's go. Thank you.
Need of communicating with people, you will have the information needed to understand communication and how it works. Use communication skills to interact with all people in your care, influence a person's behavior, interact with families and teach. Describe cultural diversity and how culture may influence behavior. Recognize since she was admitted yesterday to Morningside Nursing Home. Mrs. Morgan is just 45 years old, but as you read on her chart, you see that she often has double vision, weakness and loss of balance caused by multiple sclerosis. Sometimes her hands shake and often she has sudden, uncontrollable outbursts of anger or crying. She can no longer live alone safely. You are surprised when Mrs. Morgan says, "Come in," and are even more surprised when she looks up at you and smiles. You say, "Hello, Mrs. Morgan," introduce yourself and check her name band as you give her a firm, but gentle, handshake. "I've come to help you get ready for bed." "Thank you," she says, "for introducing me to Agnes Ryan. She is such a dear woman. I was sitting in this chair, thinking how I don't belong in a nursing home with a bunch of old people. I'm too young and I should be in my own home, with my own friends, surrounded by my own things." At that point, I had never felt so alone. I was crying, when I felt a gentle touch on my hand. I looked up and saw Agnes. Then she explained that you had introduced us yesterday when I was doing and to let me know that everyone missed seeing me at dinner. I was amazed. I wasn't seeing too well when I came in yesterday. And I didn't go to any meals today because I'm embarrassed about my weak, shaky arms. But I just couldn't believe what I was hearing. They missed seeing me at dinner. You tell Mrs. Morgan you're glad to hear that Mrs. Ryan stopped in to see her. You mention that Mrs. Ryan makes beautiful quilts. Do you think she would show me one? Rachel asks. You tell her yes and suggest that Mrs. Morgan ask her during lunch tomorrow in the dining room. I think I will talk with her tomorrow at lunch, Mrs. Morgan says, and smiles. Using communication to interact with others. As you read in the previous chapter, people can be hard to understand. But they do not have to be a mystery if you talk with them and listen to their stories. When you interact with the people in your care, you learn many things about them that help you understand them better. To do effectively in your work. Communication is the principle of care that you use when you follow all the other principles. You communicate to help keep people safe, to respect their privacy, to give them dignity, to promote their independence and to help maintain infection control. Your ability to send and receive messages helps other people understand you and makes it possible for you to understand others. You may think that communication takes place only when you talk or write, but much communication takes place in the expressions on your face, the grip of your handshake or the tilt of your head. How communication works. You probably know from personal experience how common it is for people to misunderstand one another. When you talk and someone misunderstands you, you may react by thinking, "What I said was so clear." Effective communication requires more than chatting information. You tell Mrs. Morgan that she could ask Mrs. Ryan about her quilt making tomorrow during lunch. Mrs. Morgan says she thinks she will do that. You are the sender. The suggestion to talk with Mrs. Ryan at lunch is the message. You use verbal communication as the channel. Mrs. Morgan is the receiver. Confirmation occurs when Mrs. Morgan says that she thinks she will talk with Mrs. Ryan tomorrow. For example, a man who talked to a nurse about the care his mother received became so upset that it didn't make sense when he spoke. His message might have been understood better if he had calmed down before he spoke or if he had communicated through a different channel, such as a letter. Other times, misunderstanding occurs when the receiver does not confirm the message to the sender by telling the sender what she thinks the message means. If you are the receiver, confirm the message by repeating, in your own words, what the sender said. If you are the sender and you have to ask the receiver for confirmation, ask an open-ended question, not a closed-ended question. For example, the man who was talking to the nurse about his mother could have said, "Do you understand?" A closed-ended question, and the nurse could have said, "Yes," even if she didn't understand. However, if the man had said, "What do you understand about the situation that I just explained?" An open-ended question, the nurse would have answered by repeating the man's message in her own words if she understood him. Good communication requires much thought, careful attention, skill, and cooperation. It also has many benefits, including increased understanding among people. Choosing communication channels. As a nurse assistant, you use 3 channels of communication. Verbal communication is words spoken for the receiver to hear. Nonverbal communication includes actions and expressions for the receiver to observe, and written communication consists of words or symbols written on paper or some other medium for the receiver to read. The channel that you choose to send your message depends on the message and the receiver. For example, you would choose verbal communication to send a message to someone who cannot read or who is blind. In certain situations, you might use more than one channel to send your message. For example, you could explain something, verbal communication, and then write it down, written communication, as a reminder. Or you could demonstrate a skill, nonverbal communication, and describe what you are doing, verbal communication, at the same time. Verbal communication. Verbal communication has 2 important parts. 1. What you say, and 2. How you say it. Effective verbal communication requires that you have useful information to share, speak clearly, and express your thoughts well. When you talk with a person in your care or with your coworkers, use the following verbal communication skills. Get the receiver's attention before you start talking. If the person is doing something, and your message is not urgent, it may be better to talk with her later. Use words that the receiver understands. When communicating with people in your care, be careful about using medical terms that may not be familiar to them. Because some people feel shy about asking what you mean, they may not get the message. Choose the right volume. Speak loudly enough to be heard but not too loudly. How loudly you speak depends on how well the receiver can hear, how much noise is around you, and whether you are discussing personal information. If a person is having trouble hearing you, move closer to her. Speak slowly and clearly. Talk slowly enough to express your thoughts clearly and to give the receiver time to hear and think about what you are saying, as well as the opportunity to respond or ask questions. Be aware of your tone of voice. Tend to how you sound to be sure that your tone of voice matches what you're trying to say. Sometimes, when you are in a hurry or have something else on your mind, you say things in a tone of voice that is not appropriate for the situation. For example, if you are thinking about an unpleasant conversation you experienced with the bus driver today, you may inappropriately reflect your anger at the bus driver when you speak to the person in your care. Listen to the receiver. By asking receivers to respond and by listening to what they say, you receive confirmation that they understand your message. If they do not understand, you may have to send the message again in a different way. Wait until the person who is talking stops speaking, then begin to speak. If they do not stop, politely say "excuse me" and wait 1 minute so that they may respond. Nonverbal communication. A performing mime never speaks. He or she uses only actions, nonverbal communication, to send a message. Information and feelings often are shared through body movements and facial expressions. Sometimes these actions are called body language. To communicate effectively, you need to understand 2 different elements of nonverbal communication: receiving information and sending information. When you look at people, you notice their facial expressions and how they hold their bodies. The information you receive from their faces and bodies affects how you interpret their messages. If you talk to a woman whose arms are folded tightly across her chest, you may think she is angry or upset. You interpret this message not by what she says, but by how she holds her body. However, her arms may be folded because she is cold. A person's background and culture also can affect nonverbal expression. For example, looking a person in the eye is a form of respect in some cultures, but it is considered offensive in others. When you receive information through nonverbal communication, ask the sender whether you are interpreting it correctly. On the other hand, you must be careful about the information you send. Sometimes you have to keep your feelings inside so that they do not show on your face. For example, when you provide care to someone who has an infection that neither looks nor smells nice, you must keep a calm look on your face so that the person does not feel afraid or rejected. If a situation really bothers you, you may need to excuse yourself, get a breath of fresh air and return. Be aware of how you hold your body and what you are doing so that you communicate the right message. For example, if you are pleased about something, make sure your facial expression, perhaps a smile, and body, standing erect, as well as your words, communicate your pleasure. The same nonverbal clue can signal many possible messages, which the receiver needs to check out. Con side of the following aspects of nonverbal communication. Personal appearance. When you look professional, by wearing clothing without stains, wrinkles or holes, and by polishing your shoes, keeping your hair clean and neat, and trimming your nails, you send the message that you care about yourself and the people you are with. Facial expressions. The meaning of facial expressions can vary. For example, a smile can be a sign of welcome or a sign of approval. A frown can suggest unhappiness or annoyance. The look in a person's eyes can show understanding or confusion. Keep in mind, however, that a facial expression can be affected by specific developmental disabilities where the person does not look at the person to whom he or she is speaking. In this circumstance, it is best to use other means to confirm the listener's understanding or feelings. Touch. A caring touch, such as a hand on a shoulder, a pat on the back or a hug, is often a good way to make someone feel special or emphasize what you're saying. However, as you know, touching is not considered appropriate in all cultures, and some people simply do not like to be touched. It is important to remember that physical touch can be very disturbing to individuals with specific neurological disorders or conditions. This is called tactile sensitivity, and should not be taken personally by the caregiver. Sometimes, because of how you feel, it is not appropriate to send a message by touch. If you feel angry, tense or impatient, you may want to grab, slap or shake a person, but you must never touch a person in this way. If something is bothering you, talk about it right away with your supervising nurse or with someone else you trust. Body position and movement. People in your care communicate how they feel physically and emotionally by the way they move, stand and sit. For example, a person who usually sits up straight may be slouching in his chair today. His slouched position may indicate that he is in pain, tired or feeling depressed. You also send messages when you move, stand and sit. Move toward people slowly so that you do not startle them and so that they do not think that you are in a hurry or that you do not want to be bothered with them. Where you stand or sit in relation to another person also is important. Every person has a comfort zone. Your own comfort zone may allow you to stand very close to others, but some people in your care may find your closeness uncomfortable and back away. Or you may need a lot of personal space, but someone in your care may think that the distance means you do not like her. Be aware of each person's comfort zone, and find a distance that feels right to you and the other person. Written communication. In your work, you often communicate by writing telephone messages for co-workers, reminders for people in your care and information for your co-workers about the people in your care. Before you write a message for someone in your care, find out whether she will be able to read it. Her ability to read may be a source of pride or embarrassment. Although she communicates well verbally, she may not be able to read because she never learned, she does not read English, or she has problems with her eyesight. To find out about her reading ability and protect her dignity, talk to her or her family members. Then, when you do communicate in writing, use the following written communication skills. Write neatly. If your handwriting is hard to read, print instead. Choose the best size and colors for your letters. If you write something for a person with limited eyesight, use large letters and a black or dark blue pen or crayon on white paper. Draw pictures. Sometimes a picture says more than words, and it communicates well to a person who cannot read. Choose simple words. Use the simplest words you can to get the message across. Be specific. For example, if you are noting a time, be sure to write AM or Prime Minister if two people with the same last name are in your care. Provide additional information, such as their first names or their room numbers. Be thorough. Make sure that your message is complete. Spell correctly. If you are not sure of the spelling, look it up or ask. Include your signature. Always sign your note so that people know who wrote it. Double check your message. To make sure that you have not made any mistakes, check over what you have written before you deliver the message. Computers may be used to communicate information about the person, to obtain your assignment or to record observations or tasks that you have performed, or even to take a nurse assistant examination. As with any piece of equipment, the more familiar you become with it, the easier it is to use. If you do not own a computer, you may be able to go to your local library to practice. If you feel uncomfortable, ask for assistance, and remember, the more you practice, the easier it will become. Whether you use verbal, nonverbal or written communication as the channel for sending a message, you want to do your best to make sure the message that you intend is the message that you send. Using clear communication when providing care.
Okay, so that's practically a very short video that has taught us a lot of things in just 15 minutes concerning what we need to know as caregivers. Communication is important. We cannot actually overemphasize that fact as a certified nurse assistant. So like I said, I don't know how many people were actually able to see that video, because it's very clear from my end. How many people? Are we even together?
Yeah, we are together.
Okay, so let's Okay, so at this point, I'd like to hear what are some of those things that you have learned from the video? Maybe just a sentence, you saw this, or you learned you should do this. I just want maybe 3 of them before we now move to what we have. Remember, before we watched the video, I had said that I was going to ask, so we should be attentive and learn 1 or 2 things that I would like us to share right now. So please, who is going to start to build a cat?
Okay, let me start.
Okay, thank you.
Yeah.
Thank you. Can you tell us your name?
Yes, you can hear me.
Yes, I can hear you.
Okay. I learned a very serious point in this video. You know, as for me, I mostly like touching whenever I'm talking to someone, because I feel that when I touch you, even if you are
Connect more.
angry, you feel comfortable when I touch you and I express my feelings to you. But
That's
today, I have understood that touching someone sometimes due to our individual emotions and anger, you might not know how the person or what the person is going through. So you touching them, and not everybody like the touching ideas, it can create some difficult expression on their face, or they might not even like you to treat them or communicate with them. So in this sense, you have to be careful communicating with people by touching. Though sometimes it might feel good, but at the other hand, it might not also feel good to the other person. So we have to be careful how we communicate to patients and every other person.
Thank you so much. I guess that's Mr. Isaac. Am I correct?
Yes. This
Okay,
is Isaac.
Mr. Isaac, thank you for that. Thank you. Thank you for that. So you see, it depends on the person. Like we say, we have different cultures. So it depends on the person's cultural orientation, just as you have said, and we have seen there. So we should know when we should touch, because it's not appropriate at all at times. Thank you so much. Stephanie Ogbu, I don't know. I saw that. Stephanie.
That's
Can I go? This is Hope.
Okay,
three hands.
my name is
hands
Martha.
up.
My name is
Okay, Martha,
my name is Martha. So I don't know.
Okay,
I just had to
Martha.
change it from Stephanie. It's Martha.
Okay, Martha. Martha, go ahead, please.
Okay.
Which of the
So I
Marthas,
also
please? Which of the Marthas?
Martha Ochibo Ogu.
Okay.
Our
Okay, punctuality prefect. Go ahead.
Thank you. So I also learned about the non-verbal means of communication, where you talked about personal appearance, sending a message about how you care about yourself, and also facial expression also, like smiling and all that will also send the right message to the person you're giving care to. And then I also noted the part where you said we should speak slowly and clearly so that the person you are caring for would understand what you're saying. And then I also took note of where you said we should not transfer aggression. We should not transfer aggression. So the way we talked about the bus driver, if you have a problem with the bus, and then when you get to where maybe your patient or the person you're caring for, do not transfer whatever anger it is. Don't transfer the aggression to the person you're caring for. So that's the point I took note of.
Thank you so much, Martha. That is beautiful and elaborate. Thank you so much. So that's practically it. You shouldn't transfer aggressions, especially women, because we have a way of being very emotional sometimes, and we just take it all out when we go to do our duties. Thank you so much, Martha. Did we have any other hand raised, please, before we move? Because we have.
Good evening,
Pardon? Good evening. Good evening. Patience.
Okay,
my
so
name
I
is
just
Comfort.
this is Patience.
Okay, hold on, please. Let's hear from Patience. Comfort, please. Go
Okay,
ahead, Patience.
So for me, from what you have taught and from the video, it's just the emphasis or the need for us to really understand that communication is two ways. And very underlining is the fact that it's really about us, it's about the person that we're caring for. And so it appealed, the aspect of active listening really appealed to me, because if you are able, by profession, I'm a salesperson, so and I know the importance of active listening, because when you listen actively, it helps you to understand objections.
Yes, correct.
And when you are listening actively, you go beyond words. You could see the body language, you could know where objections are coming from, and that will actually put you in a position to be able to answer those objections that are being raised. And once you can pass through any objection raised, you discover that your communication is effective. You are able to solve whatever problem or whatever issue that is being projected at that point in time.
Thank you so much.
One other important thing about active listening is really like for you to even be sure that you have listened. So first of all, you are intentional about it, and then for you to know that you have listened is for you to re-emphasize or repeat what you have summarize everything that your care person, the person you are caring for, has said. For instance, you want to say something like, okay, if I understand you, these are the things that you have said, and then the person gives you an affirmation, and then you are part of it. Sometimes also people don't just want, they're just not talking to you because they want you to take action. Sometimes they are talking to you because they just want to be heard. They just want you to listen to
show that to
So you are just, at the end of the day, you are picking those salient points if you have listened actively, and you are able to use it to solve whatever problem that you think at that point in time makes sense for you to revert to. So I'd just like to
thank you so much. Thank you, Patience. That's beautiful. Thank you. I am happy because when anytime I have to use this video, any other of such videos, I see that people really understand better than me doing a lot of talking. So thank you so much, Patience. We still have hands raised. Wow. Okay, Comforts, please. Comforts, please. Can you talk now? Sorry. Comforts. Good evening,
yes,
Comfort. Okay.
Islander, we should be a good listener, and also we should understand that we have individual differences.
That's correct.
Why our patients, we should be friendly, not transferring of aggression, and we should assist them in one way or the other. Anyhow they need our assistance, we should do.
Thank you. Thank you so much, Comfort. That's beautiful. So I think we can move. If we don't have any other question, we can move. So we are done with that. Thank you. I'm happy we all understood. So communication cannot be overemphasized. Please, we have to mute our mics, like we always say, but I don't know why we still have a couple of... All right, so we want to look at the next module, which is medical terminologies. For this particular one, we are just going to go through, scan through, and run through. You are going to have the slides, so you can take your time in case you have any question. You just drop it on the platform. I'll answer, or you do research. We have the Google, or you ask me anyhow. But we are trying to see how to take the ones that are very important. Like most of these things, the reason I'm saying we will not delve too much into it is because we are going to have practicals. Like I told you, the next 2 days, we are not doing any theory thing again from tomorrow. I mean, after tomorrow we'll complete the dementia care. We'll see how to treat the person with dementia and the last 3 modules. And then next week we are done. We have the 6-hour stretch to do our practicals. We don't have any theory. So these, like I said, CNAs are not actually involved in the direct medical procedures, like I had said earlier. CNAs do more of assisting the nurse assistant, I beg your pardon, assisting the registered nurses and also attending to their patients. So attending to the patient depending on instructions given to them or their own job jurisdiction descriptions. So these are some terminologies that are important for us to learn, just to know, because when we know, it's easier when we hear them, we understand what they mean, and we just flow. Like you can see here, we have the ambulation, the movements, and that's one of the duties of the CNA, ambulation, to ensure that you move your clients. You know, if your client has issues with mobility or maybe to move around. Then anorexia, that is lack of appetite for food. Sometimes you have a patient that does not like to eat, has a lacks appetite to eat, you know, and it's your duty to know, instead of going to say, oh, this is my patient, this person, in fact, today I've observed that this person lacks appetite. So you can say, oh, that person is actually suffering from anorexia, like what you have observed. So when you communicate like that to the nurse easily understands. And these terminologies are things that you would see in the course of your duties. Now we have the atrophy. And this one talks about wasting away of muscles. Sometimes you see old people, and you know, you see that their bone has actually detached from the flesh. Like you see their flesh that sagging, you see that, that is, I don't know how to, I think that's the easiest way to explain it. Sometimes you see it mostly happens with people that are old, you know, by the time, because of age, their bones tends to detach away from the skin, and the skin becomes flappy. So such situations, we are going to have to see them, especially if you are in the hospice care department, where you have terminal illnesses and elderly people. We also have the biohazardous wastes. These are things that maybe substances that are contaminated with blood, and we have special places we empty those things as we progress. Now, CNA, like we said, if it is the real nursing training, like the nursing training, you would see that most of those things will be dissected, will be explained, will be bed for certified nurse assistant. Like I told you, your duties are majorly in the reporting, supporting aspect, and then reporting. You don't actually get involved with actually moving into maybe assisting with conducting of surgery and doing those very medical procedures. So, but it's important that you get to know all this. So as I was saying, then we have chronic illnesses too. There are some sicknesses that some patients that maybe we have to attend to that actually have chronic illnesses, that's serious illnesses that can last a long time, at least 6 months. So there's a difference between someone that maybe just came for maybe one issue or the other and will soon leave the hospital, and a person that is termed to have a chronic illness. A chronic illness is a serious one. Then we have the catheter too. We have the constipation, difficulty in passing feces. We have the stenotic too, the blueness. Sometimes you observe that you see your clients, your patient's skin turning blue or purple, whichever way. Sometimes it looks more like purple, it looks like blue. Sometimes you see their skin maybe get squeezed and then turn to maybe blue, getting blue or getting purple. You know that is a particular situation that you should report. Like I said, it's not for you to treat because you are not involved in but the essence of you having these terminologies is so that you can report, you can document, and allow your nurse to be aware of your observations as a certified nurse assistant. Then we have other terminologies as well, like the delirium, dysphagia, when someone is having difficulty swallowing. Sometimes you see some people, they have difficulty swallowing. It's not even it's someone being ill per se. Sometimes you see that naturally people that are not actually in the hospital, they have that dysphagia condition whereby they try to swallow. Because of that, they try to give them things like pap, like custard. They prefer than giving them hard things because it gives them or rice, something that they have to chew and swallow. It takes them a long time, you know, for them to do that. So you can have such patients that have such situations, so that when you are reporting, you know exactly what that particular condition is. There are so many terminologies, are so many that if we have to put them into slides, would have more than 1,000 of it. So which we will not be able to contain. So, but for the purpose of this class as certified nurse assistant, since it's not a medical class proper, and it's not a nursing class for the registered nurse, I just decided to just pull out some that will be important to you. Then, like we have here, we have the enema. Mothers understand that, like say, oh, enema, like you want to introduce something through your child's anus. Maybe some parents believe in doing that. They say, oh, this boy has been taking a whole lot and his stomach is actually dirty. It depends on our cultural beliefs. If you want to go in the, if you want to do it in the traditional way, they have this pump they sell in the markets that they use, or they have this tube to enema that they just put it through and they put water into the child's stomach, believing that it's going to clear the stomach and child better, you know. So we have a whole lot of things like that. We have the Gates belt, we have geriatric nurses or geriatric. This is, it talks about old people, people that are elderly, people that are aging population. So we have the geriatric nurses themselves. They deal with that, their area of specialty. They deal with these old people. They understand illnesses of old people. They understand their idiosyncrasies. They understand everything that's got to do with elderly people. So without wasting time, like I had told you today, we will not stay till 8 o'clock, I can assure you. Now, we want to look at care planning and documentation. Care planning and documentation. This is a very, very important aspect of our duty as caregivers. As a certified nurse assistant. Yes, like I told you the other day, even if you hear me say caregiver, understand that a certified nurse assistant is a caregiver. Anybody that renders care to a person, whether you are being paid for it or not, you are a caregiver. You are dealing with your elderly mother, you are a caregiver. You are handling your child that is not feeling well and trying to give care to that child, you are a caregiver. So in this case, before we continue, I'm so happy that network is better today than the other day. So before we proceed, are we together, please?
Yes, ma'am.
Yes, we are together.
Okay, I just need to hear so that I'll not be talking to myself, because that's another kind of illness that I don't like to have, just talking to yourself and nobody's hearing you. So we want to look at care planning and documentation. And care planning is, I want you to understand, care planning, the major duty of planning care, a patient's care, is not that of the certified nurse assistant, is that of the nurse. I want you to understand before I start. The duty of planning care for a patient is that of the nurse, of the registered nurse. Good. But why it is in our curriculum is that it is important for you to know, because as time goes on, some of you may wish to progress to be registered nurses. You want to take, go higher in the hierarchy. And aside that, because you are part of the care team, you need to understand how this care is being planned. Very, very important. That is why it is here. So I needed to let you know first before we delve into it. So as I talk, I'm going to tell you the duties that are for you, and I'll let you know the duties that the nurses actually do, so that you know how you come into the picture and how you can play a role in helping these nurses to actually do their duties judiciously, because you are an assistant to them. So they cannot effectively function without you. So you need to know how you come in. So let's start by looking at this care planning. Care planning simply is just a process that ensures that your patients receive individualized, comprehensive, and coordinated care that is tailored to their unique needs, to their preferences, to their desired health outcomes. Now, what am I trying to say? Every patient has his or her own challenge. They have different things. People with different conditions, people with different illnesses, people could decide to be taken care of at home, in their homes, could decide to come to the hospital. So in the hospital, it is made up of except specialty, even especially within that area of specialty, people still have their different unique needs. Everybody, Peter is not the same as Paul. They're not having the same challenges. They don't need the same level of assistance, and so on and so forth. So that is why it is very, very important that a care is planned and channeled towards meeting a person's tailored, towards meeting a person's particular. When you sew, they will measure you. They know the things you want. They measure your hips, measure all the necessary places. And that clothes will be tailored to your size, to your own. When you pick it and wear, people say, yes. So that's just how it is. Care plans are different. We don't have one particular care plan. We have different care plans for different people depending on the situations that they are. So certified nurse assistants, we are going to see the role that we play, but just to give you an overview of what is done when care planning, when the nurse is actually planning the care. Now, we have what we call assessment. These are components. When a patient walks into the hospital or in a care facility or in a long-term care home, whichever facility, with the help of the doctor, you know, does his normal part of it and information, ensures, gathers comprehensive information about the patient's medical history. Very important. Current health status, what is actually bringing the person to the hospital. We'll do assessment. How does this nurse do assessment? Does assessment looking at, remember we talked about anatomy and physiology. We talked about it briefly. I told you that it doesn't actually meant to be delved deeper into because that is not for a certified nurse assistant, but you just needed to know. So like we said, the body has different systems and how they operate. So these systems are what the nurse is going to check. We'll check the neurological system, we'll check the digestive system, will check all the things, the nervous system will check all the parts to be able to ascertain the person's health status as at that time that the person is moving into the facility. These are some of the things. They'll also ascertain the functional abilities of this person. What are the things this person can do? And what are the things that the person would need assistance? Remember, we are talking about coming up with a care plan. So in the process of coming up with this care plan, that's the first thing that the nurse does. After doing that assessment, then they go to problem identification, analyzes this assessment data to determine the patient's problems, the needs, or the nurses or the nursing diagnosis. Maybe that's where they'll have to do the normal vital sciences, do the normal things that are needed to be able to really know what is the problem of this person. Then we get to goal setting. Establish patient-centered goals that are specific, relevant, and time-bound. Those goals that are achievable. You don't go and look for goals that you know that it's not possible to achieve. Step by step in the ladder towards doing everything possible to ensure that the patient gets better. That is what a nurse does. All right. The nurse also does intervention planning, developing a plan of care that outlines the specific interventions, the actions, and the responsibilities of the healthcare team to address the patient's identified problems and achieve the established goals. Now, that is where a CNA comes in. I want us to pay good attention. That's where a CNA comes in. Do not forget, like I said, the nurse is in charge of putting together this care plan. After the assessments, after everything, the nurse will put together the care plan. Then how do you now come into the picture? You are going to be part of you are in the healthcare team, and you are going to be one of those persons that will actually implement this care plan. That is your own implementation. That's actually carrying it out, especially in the aspects of daily living. In that aspect. So you see that you play a vital role in the care planning scenario. Okay, for instance, now, as the certified nurse assistant, you help the patients with the things that they can't do for themselves. That will be in the care plan. Because having assessed this patient, let's take, for instance, I like to give examples. So let me give you an example so that you will understand what I am trying to say in a nutshell. For example, Mr. Henry, let's say Mr. Henry walks into the care facility after the assessment and everything. It's discovered that he had a stroke and he has a right-sided paralysis. He has a paralysis in the right side. Now, the nurse will sit down and say, oh, he's paralyzed in the right side, but he would need help with doing a couple of things. He will need help to eat. With right side paralysis, how is he going to go about that? He will need help with toileting. He will need help with grooming. He will need help with dressing. The nurse will sit down and look at these things and say, okay, so if that's the case, he would need assistance in dressing. He will need assistance toileting. He will need assistance grooming, and he will need assistance to dress. So who do you think gives this assistance eventually when the care plan is come up with? It is the certified nurse assistant. That is where you come into the picture. That is where your role is very important assistant because you actually do activities of daily living. So it is very, very important. So now, another patient, Martha, another Martha, not the one on. So Martha had a left hip replacement. And because she had a left hip replacement, she needs help with bathing. She has hip replacement, so she will need someone to assist her with bathing. That's activity of daily living. So who will do that work? Is a certified nurse assistant. Okay, we also have another patient, Bob, that has a recent leg amputation and diabetes. He needs help with all tasks because he's diabetic. He's a person suffering and having diabetes, and he also had leg amputation. So you know what that means. He needs help. What of Annie? Annie has dementia. She needs reminders and direction. So you see, when the nurse is actually putting up this care plan, knowing what are the challenges, knowing what are the problems of this particular patient that has walked in, the nurse now sits down and tries to put together the care plan that, okay, this is how we can help. This is what to do. This is what you would do. And this is what you do. So when the nurse is done with all those, that is where you now come into picture. Okay, this is the care plan. Mr. So person would need help with this at this particular time. He would need, because of his condition, he wouldn't be able to be moving and going. So you would need to, at this point in time, at this particular time, to assist him to do this and assist him to do that. So you see where a certified nurse assistant, you see where it is where your duty is very, very important. Just as people have different needs, different patients have different needs. So it is important that you need to know what kind of needs. Some patients may need help brushing their teeth, while others will do it themselves. Others will say, no, they wouldn't need that help. They will still be able to make use of their hands, depending on the challenge that they have. So you see, because people have different care needs, different challenges, so are the care plans different for everybody, depending on the challenges that they have. So people have different care plans, and it is your duty as a certified and nurse assistant to work with the nurse so that you get to know what are the specific things that are required of you. What are your duties? What are you expected to do for these people, depending on the challenges that they have. So like over time, a couple of people have asked, when I have the certified nurse assistant trainings, I remember a lady actually asked me one of the badges last year or so, how do I know what I'm supposed to do with each patient? She was like, madam, how do I know? So I tried to say, like I said earlier, that is the duty of the registered nurse to do a head-to-toe assessment and review of all the systems in the patient's body for real, to find out what are the real problems and the potential problems. There's a difference between the real problems and the potential problems. The real problems now is, for instance, a person has issue with toileting, like we talked about, and the person is bedbound. That's the real problem. A person cannot stand up from the bed. Of course, there are other related potential problems. Because the person cannot stand up from the bed, the person would need to be turned, to be repositioned at close intervals. The person has to be repositioned so that the person will not have bed sore on the bed. So you see that because of that particular problem of the fact that the person is bedbound, maybe is having a mobility issue, serious mobility issues, or is having a challenge that the person cannot leave the bed, that is the main problem. That's the illness. That's the main problem. But what are the attached issues that could come from that? What are they? Because the person cannot move, what are the potential problems? Because the person cannot move, the person is bound to have constipation. Is not agile, cannot move and move around and allow food to die. So the person is bound to have constipation. The person is bound to have bed sores if the person is not repositioned. So you see, there's a difference between the real problem and then the potential issues. Now, after the nurse does all those things, you yourself, you know you have to spring to work based on the care plan, because a care plan is developed. And then from the care plan, you now know what your duties are for you to do. So there's actually an acronym, like I said, it's just for you to just have the knowledge. There's an acronym that is called TEAMS, TEAMS. It's called TEAMS. Now, what is that? It's for you to have the easiest way for you to just know how to come up with a care plan. The nurses know what I'm talking about. Toileting for T, eating, E, and then ADLS, activities of daily living, M for mobility, and then S, special, those things that come along the way. So like I was trying to say, if someone cannot eat, of course, if a person is bedbound again, the person will not be able to sit up. It's difficult. If a person is having a serious illness that is making a person bedbound, the person will not be able to sit up in bed, and that poses a challenge for you. So I don't know if we are together, if network has permitted us, because now I can see that we are 16. Some people.
Please, can you share that?
Okay. The acronym is actually for nurses, but well, that acronym is TEAMS. Teams. TEAM and S. The reason I didn't put it here is because, like I told you, it's the duty of the nurse to actually know how to share, to divide the duties and allocate to you. So you continue from there. But it's important because you may wish to go further. So what is that TEAMS? T is for toileting. It's for toileting. So you understand if this person will actually have toileting issues. Oh, is the person bedbound? Is the person someone that will be able to move and go to the toilet? That is the toileting aspect of it. Then eating. What is the person's eating habit? Will the person be able to feed himself or be able to feed herself? That is for the eating. So when you are planning these things, that's where the nurse will now look at these teams. She will now filter the duties that you as a CNA will perform for that particular patient in your care. So, and then hand you the care plan. Then it is your duty to follow the care plan to do what you have to do. So T is for toileting, E is for eating, A is for ADLs. That's how it is called, ADLs. That's activities of daily living, like brushing the teeth, like taking bath, those things that you do every day, activities of daily living. Then M is for mobility. You look at mobility issues. Is this patient someone that will be able to walk, or will the patient need the assistance, or will the patient need the certified nurse assistance to actually take him or her for toileting issues or take him or her to the toilet? These are things. That's why I say that our duties as certified nurse assistants, you are in a support role. It's just like a movie. You are not a lead character. You are in a support role. So you need to be given everything that you need to do. And then you have to understand how to do it so that you can do it efficiently by the nurse. So why S is special? What I mean, what is special? That is, there are other duties that may come in handy for you to do. Other duties that are just there that you may be asked to do it depending on your level of training or your level of being, depend on your job description, let me say so. So like I was trying to say, like eating too, like we talked about eating. Under the eating, the nurse will find out, does she have issues with her teeth? Something you have to check. Does she use dentures? If she uses dentures, then part of your duty is to ensure that those dentures are kept properly, ensure is now treated, the person is now able to use his or her legs, is now able to move. So you see that the care plan will change. It will change from someone being totally not immobile, that's not able to be walk, and someone that is not able to walk. So you see that care plans keep changing, it keeps moving. It can change at any time because someone gets better. It could either change as a result of the fact that the person is getting better and the person doesn't need most of those duties that was actually done. Remember that in your profession, as much as possible, you have to ensure that you respect the preference of a patient. You have to, as much as possible, ensure that you don't take away the control from any of your patients. Let them do the things that they can do and only assist them in doing the things that they cannot do with their consent, with their due informed consent that you can do that thing before you do it. So like we watched on that video, it is very important, communication. So as you see these changes, it is your duty. You may even be the first to see the changes before the nurse. So it is your duty to document. It's your duty to bring it to the care team that, oh, I can see this person is actually, because the time at first I used to take him, this is the way he used to walk with one leg. Now he can comfortably walk with 2 legs. So anything at all that you see, you have to document. And when it has gotten to the stage whereby that person is actually free of that particular duty that you do, the care plan has to change. It has to be updated so that they'll say, okay, Mr. John no longer needs this. So as such, you, the certifier, you are not going to be doing this aspect. You are going to be doing this. So care plan keeps moving. And also, the nurse, another very important thing is, like I said, the nurse needs this, because it's going to be based on the information that you put across to her, that or him or her, that will help them to keep formatting, keep updating, keep upgrading the care plan. They need this information to be able to do the things that they need to do, to keep changing the care plan, to make decisions about the patient, to discuss with the other care team. They need to get this information from you. So you, as a certified nurse assistant, reporting these observations, give this nurse another opportunity of assessment, because like I talked about the man that could use 1 leg and then after use 2 legs, that particular information, if it is put across, they need to gather the care team, maybe the therapist, that will come and help with the legs, you know, maybe to check, maybe to check. They have to now maybe do an x-ray, do another thing again. So you see there's going to be another assessment so that they'll see the healing effects, or how far this person has actually healed, what can be done, what cannot be done. So you see that the care plan is a continuous thing. So someone had actually asked me, like I like to share my experience, a nurse again, sorry, I beg your pardon, a certified nurse assistant that was actually having a training, one of these trainings last year batch, had asked me a question that, won't the nurse be annoyed? Like she was just being real. Like she was just being very real. That won't the nurse be annoyed if you have to ask everything? You know why? Because I told her that you have to ask. If there's anything that you don't understand, there's anything that you need to do that you're finding it relates with the nurse. The nurse is you. That is, just ask. Don't attempt to do anything you don't know how to do. Why? Because if issue comes, you'll be on the other side of the law. And of course, the nurse bears 3/4 of the burden of the legal implication of any care that goes wrong. That's what I want us to understand. So for you to help the nurse and also to help yourself, remember you are assisting the nurse. You have to ensure that you report everything. So when she asked me, won't the nurse be annoyed? I said, of course, the nurse doesn't have to be annoyed, because anything that happens, she's going to bear the legal implication, 3/4 of it, like a full 1 whole. She's going to take 3/4 of it, and you will go for 1/4, because you are in a supporting role, because they will blame her or him or her for that. Yes, you are not helped in the legal aspect to a large extent. It's the nurse that bears it, but you have to help so that such scenario does not occur, because you are the one that sees firsthand anything that happens. So like primarily, okay, so when she asked me that, I said no, that the nurse cannot be. And because you as the CNA, you cannot you can't alter the care plan on your own. You can't. It's only the nurse that can see, assess, and then say, okay, this should be like this and that should be like this. You cannot on your own say, okay, this man now can walk with 2 legs. Oh, okay, if that's the case, no, I cannot help him again. For now, I can't help him since his 2 legs are okay. I won't be able to help him in mobility issues. I've seen that he can actually walk, you know, limp a little and actually do some things for himself. So let me change. No, you don't have the right. So it's only the nurse that can change it. And because you cannot solve any problem, then you cannot alter the care plan. So let's move. Documentation too. We cannot overemphasize that. It is important.
She said this note, all these notes that she's explaining is in this thing.
Someone is actually talking. Don't worry. You know, as I like to do, you will get the slides. So it's important you hear me talk, because you will get the slides. What you will actually get a recording is going to be the practicals. That one is going to be recorded and live. Like I said, it's always a live practicals where you would see with your 2 eyes, and you can pause and say, ma'am, why is the leg taken like this? Or why is this? And why is the vital signs checked like this? Can I see the number? Why did not? Good. So that's why we like to make it live, and we don't want any theoretical thing to come in between those 2 days, so that we'll have all the skills that we need to. So like I was saying, documentation is written. If you observe, I keep saying reporting. Reporting is more of an oral work where you have to say, this is what happened, that is what happened. But it should align as you report, you are also documenting, because that's what you have seen. And anything documented, like I tell people, you must ensure that you sign, at least you document. And the documentation you are documenting, of course, who are you submitting it to? The registered nurse, of course. So the registered nurse will have to go through, will have to look at it, dot the I's and cross the T's, will now have to put it in such a way that she can report to the higher authority or in the higher people in the ladder. You understand? So documentation is very, very important. Why? Because like I said, like you can see on this slide, it may serve as evidence of care in a law court. If there is a challenge that there is maybe misappropriation of funds or care, sorry, not funds, but care. And there's any issue, maybe you are held for negligence, or the nurse was supposed to do this and the nurse did not do, and it gets to a legal battle or anything like that, you know now that documents are what will actually speak for you. When it is documented that so time I actually did this, what I was expected to do, it was done like this, it was done like this, it goes a long way in helping you. So it's always advised that there should be written documentation of whatever that we are doing, you know, because it may serve as evidence in a court of law, and it provides data for quality assurance. It's a follow-up. It's a follow-up for the care team to see how far. It's like to say, this is what it was and this is what it is now. So it helps, it helps as a follow-up for you to be able to track the success report or the healing progress of a particular patient. So all these things are very, very important for us to take note of. Okay, this is almost 7 o'clock. I said we shouldn't get to 8. Fine. So as I was saying too, like before I forget, some things I can't, if I keep emphasizing things, like it's a part of me to emphasize things that are very important. So if you hear me keep emphasizing something, or I keep bringing it, because what happens is BCC, like I like to say, BCC UK, the people that pass through us over the years, they always find a way of getting a form of attestation from us when you are eventually taken anywhere. It doesn't have to be outside, even if it is in Nigeria. For one reason or the other, they may have to do some form of background checks. You know how these things work. So that is why anybody that passes through us is like you saying, yes, I can, to a large extent, to an extent, I can vouch for this person that, yes, at least this person learned the principles of communication. The person will be able to do this, the person will be able to do that, even though not 100%. You understand? So why am I trying to say this? Is very, very important that we get to know these things. We don't take it for granted at all. We don't take it lightly. Anything I emphasize, if we as certified nurse assistants, like I said, that our duty is very, very crucial, because we have a first-hand interaction with our patients. So even when you see anything as little as a redness, we are talking about documentation here, or report, maybe on the skin, you see bruises. Remember, abuse is also something. Sometimes these elderly people, these ill people are abused. They are vulnerable. So people tend to take advantage of them, like I like to say. So you as the CNA, anything that you see out of the ordinary, please report. You see redness, you don't wait until maybe when it is now proclaimed that, oh, this person was actually abused. That's when you say, oh, when I was actually taking care of the patient's skin, I actually saw some. It clearly shows the world that you don't know what you are doing if such a situation arises, which I know it won't. But it's just an illustration. If the patient, maybe you are taking the patient to the toilet and you hear wheezing sounds, you hear maybe the patient sneezing, or you hear something out of the ordinary, please let the nurse know. You can report and also document if they need that, because not everything totally you document, but some things could just be maybe report. As you report, the nurse will now follow up by coming to actually check what is the problem. Why was this person wheezing? Or why is there redness all over the body? And so on and so forth. Equally, coughing as well. If you notice that the person is coughing while eating too, maybe in the course of you doing your ADLs, trying to feed the patient, and the patient is coughing, it is important that you report immediately to the nurse. You are playing a support role. So immediately you report and the nurse takes over from there. So please, anything at all Do not. Anything, if you are not even sure of reporting, just report, because it's not a crime to report something, even if it's not something to be reported. At least you have done your bit. So that is very, very important for us to take note at this point. Okay, now what is your role as a CNA in care planning documentation? Your role cannot be overemphasized. It's just a walkthrough of all I have talked about. As we said, that the nurse assesses the patients to determine the challenge. It's not your duty to assess the patient to actually know what is wrong with the patient. It's not your duty. It's the duty of the nurse, of the registered nurse. Good. And so it is your duty to receive instructions and directions from the nurse. Read and follow the care plan, like I told you. When the nurse comes up with the care plan, depending on the assessment, depending on maybe the head-to-toe assessment, the challenges that the patient has, the next thing is for her to come up with this care plan for the team, the healthcare team, and people that work with this person. Then you as the CNA, you are given the care plan. You know your duties. I'm to take for toileting. I'm to do this. I'm to do that. These are things that you need to read and follow the care plan. Exactly. Like follow the care plan and go with the rules. You are the hands and feet of the patient. Why did I put that? Because as the certified nurse assistant, you are there with the patient. The patient may, for instance, maybe a patient that is catching cold and may just need a pullover. You understand that it's just stretched there. And maybe you considering that, okay, it's important for him or her to wear the pullover, or maybe you speak to the nurse says, okay, it's right for you to give the pullover, because certain situations, maybe the person is supposed to be left to sweat, maybe as a result of one challenge or the other. You know, these illnesses can bring so many things. On a fine day, a person that doesn't have challenge, you may be cold and you just reach out and wear your pullover, but for some certain reasons, medical reasons, you may not be allowed to stuff yourself with pullover even when you are sweating as someone that is ill or in a health facility. So that is why it's important that you know exactly what to do at any point. So you are the hands and the feet. Get me water, reach out for this. Please, can you get me that? Oh, I just need to read that book that is over there. Can you get it for me? So you become, in most cases, the hands and the feet of the patient, and then report everything you see. That one I don't want to talk about. I don't want to overemphasize it. We've talked about it too much. Anything you hear, anything you see, anything you smell, anything you feel, report to the nurse. Don't take anything for granted, because any of those signs could be a dangerous underlying illness. There, you know, there are people that have comorbid situations. Comorbid situations are situations where someone has more than one illness. Maybe a person that is hypertensive is also diabetic. He also has maybe schizophrenia or has another. So you see that there are people that have comorbid situations, conditions. So there may be things that can just shoot up in the course of you are treating this one because of that other situation. This thing is happening. So anything you observe, as fast as possible, report to the nurse, so that they can assess. That's where the nurse and the team will now have another opportunity to assess and see what's actually going wrong. So as the care plan is being reviewed, like I told you that a care plan is not cast on concrete, depending on what is actually wrong, what's the challenge with the person, with the patient. If the person gets better, good. If the person is not getting better, you know, these things is two sides. If the person is not getting better and they may need to extend to give you more tasks as a certified nurse assistant. Maybe the first was just help, but as time goes on, the condition of the patient has deteriorated such that maybe he or she has to have more challenges that will need help, that will need assistance. So your own job description now has to be increased. They would have to give you another care plan that extends to handling the new challenges as a certified nurse assistant. So you may get new tasks to do. It just keeps moving. It's a continuous process until that patient is discharged or anything happens along the way. So at that point, at this particular point, I want to just pause and see if anyone, I would just like to ask before we get to the last model for this evening. Like I told you, we shouldn't exceed 7:30, God willing, because today we just had more of the theoretical aspect. So having heard all these things said so far, I know just like Mr. Michael tried to tell us some of his experiences, some things that he has seen. I know that in the course of saying all these things, there must have been some experiences. And then some of us here that are already into the health field, doing one thing or the other. Can you share some of your experiences with us? Like some of the things that you have seen going on there, or some of the things that you've been privy to do, to assist to do if you are in the hospital setting already, or what are some of the things that you have seen or some of the things you have observed, or if you have any contributions to add. Like I like to say that I love to hear, I love to learn. As I keep, the more I take these trainings, the more I learn, because we learn, you keep learning until the day you move over to the other side, you keep learning. So the floor is open now because I've talked for too long, which I don't like to do. I don't even know if we are listening. Are we still together?
Yeah, dear.
Yes.
Yeah, dear, ma.
Okay. So are you saying there's no question? The people that are very, very, are you saying there's no contribution rather? Okay, there's something in the chat. Record stopped. Okay. Please go ahead. Who is asking the question?
Okay, good evening.
Mr. Chukunonso. Okay, Mr. Nonso.
I went to a facility home yesterday. So I was discussing with one of the staff. So the alarm system. I'm not hearing anything, no. Hello, can you hear me?
Me, I can hear Mr. Chukunonso.
We can hear you clearly, sir.
Okay,
yes,
go ahead.
Conversing with one of the staff. So the alarm system of the facility home, I think it was activated. So one of a lady in a wheelchair started dancing. So I was surprised that what's making her to dance and all those things. The other time, in a situation like this, what would a nurse aid or a
Okay, Mr. Chukuno, so me, I don't understand if I understood what you mean. You said that you went to a healthcare facility and the alarm system, the alarm system went off. Okay, it was falsely activated. Okay, falsely activated. Yeah. So it sends the wrong message. Okay, there are two things involved. You know, I was not in that facility, so I cannot really tell you firsthand what's actually happened, what's the instructions they have. But there are two things involved, like I said. One is that it is either, that's what I'm saying, there are two possibilities. Is either there has been some form of safety drill for them, stating that, and again, it depends on the facility that you went to. If it is a facility for the disabled.
No, it's for the disabled.
Okay, it's good. So if it is a facility for the disabled, there's what they call safety drill. And these safety drills send a particular message to them. It's just like you, even as you are now. If there's a safety drill here, we must have been practicing that when you hear this sound, everybody, once you hear this sound, know that it's time for you to lock up. We are no more continuing this training again. So when you hear that, even when it's activated falsely, there will be so much confusion because everybody will automatically say, oh, thank God, the training is over. So what am I saying? Maybe there is an instruction as regards that when they hear the alarm system, maybe they should do something. I don't know, because you said the person was dancing. I don't actually understand.
Two of them, as in like 2 or 3 people were dancing. So I was wondering, maybe they thought it's a
okay, the dancing, you know, we talked about non-verbal form of communication.
Just laughing and dancing. So while others were just looking at that.
Okay, so maybe that's what I'm saying. So there are two things. It's either is a safety drill, and secondly, it could equally teach you a lesson as a certified nurse assistant or as a care aide, because at that point, it's not something for you to make it, how do I put it? Certain illnesses can make someone to behave anyhow. That's why I say two sides. If it's not a safety alarm, then it is as a result of something that has triggered that attitude. And the dancing could be that he or she is excited. Oh, when we hear this bell, you know, wow, this is what it's, oh, I'm happy. It's just like we used to be like I used to be when I was in boarding school, when it's time to go home and I hear that bell. Oh, it's time for us to go home. You see excitement. We are packing our things. And so maybe there should be a form of a sensitization. She couldn't have reacted the way she did as a result of someone is actually, excuse me, I was still saying something, please. Mr. Chukunon, so I was still trying to answer Mr. Chukunon. So
this one, you say somebody is talking. Let the person finish.
So that's thank you so much. Thank you.
Don't teach us that thing.
So that's it. You see, we are even using it into, we are even putting it into practice, communication skills that we should finish first before another person. Thank you so much for that timely reminder. So, Mr. Chukuno, so the person could be overexcited that something is there. So certainly there's no smoke without fire. Something must have transpired. Maybe we'll be going out, maybe we are done with the session. Thank God for the alarm. But you will not understand because you just came there. You don't understand the intricacies of that place. So I don't know, but I just feel so. I just think that's the answer. So thank you so much on a very lighter note. Thank you for that, Mr. Araka. So
my second question is this, sorry, ma. Maybe we are in a care home and maybe just
so
like
Martha, I can see your hand up. Just lifting up your hand now. Martha, can you go ahead?
Okay, so I have a question.
Okay, please do.
As regards documentation and record, that part of the care planning, you said if there's anything, if you notice anything as a caregiver, you report it and document it, right? So I want to ask, hello?
Yes, I'm with you. Please go ahead.
Okay, so I want to ask, how do you do the documentation? Is it that you are going to have your own record or the hospital has
I think network
a
is
record as a CNA? Hello?
Can you hear me?
Hello?
Yes,
I
Martha,
can hear you.
please. I couldn't hear you clearly. You said documentation purpose, CNA. I don't know. Yes, I'm trying.
Yeah, I
Yes.
said that. Okay, so I said that as a caregiver or a CNA, and then you have to report everything you see or feel or smell as regards a patient or a client. I mean, a patient, yeah.
Okay.
So is it that the facility will have a record for you to document everything that you notice, or you're going to just keep a record for yourself?
Okay.
Do you understand my question?
I do understand.
As a caregiver, can you hear me? So I'm saying as a caregiver, and you are in a facility, and you're working with a registered nurse, if peradventure you discover anything wrong with the client or the patient, and you want to report it, after reporting it, is it that you have a record for yourself, or the facility has a record where you record everything that you are reporting?
Okay, thank you for that question. I think I can hear you clearly. It was breaking. Now, in a facility, like I said, your duty is in the reporting role. Now, for yourself, because you are reporting to the nurse, you have your record of whatever you see that you are documenting. Okay, let me not say reporting, but let me say, because there's a difference between reporting and documentation. Reporting is just talking. But when it comes to documentation, you document anything you see, and then your record is for the CNA. That's for this, for the registered nurse. When you are done documenting anything that you see, because if you say, oh, I saw the hand like this, and if it is something that is actually necessary that it has to be put down, that you have to put it down and then submit your documentation to the nurse. Now, it is based on what you are not submitting to the facility, you are submitting to the nurse because you are working with the nurse. Now, the nurse now incorporates your submissions, your documentation and your reports, incorporates everything and discusses with the care team to be able to ascertain whether the person is getting better or not, whether they need to step up to change the care plan or do anything like that. So that is it. You don't have like like the nurse has, you don't have like a major, I don't know how to explain it, but you deal directly with the nurse. It is the nurse that now puts it together. These are the submissions. The certified nurse said this, and this. Okay, having looked at this, as a result of that, I observed the clients and I checked for the redness. I did this, I did that. Then we have decided, or we have come up that, or I have resolved that we should do this. I think the doctor has to have a look at him and what or her, or what are we supposed to do from here. So the CNA is actually working directly with the registered nurse, with the RN. So it is the RN that is the main body behind it, that will incorporate the documentations of the CNA with what she has seen to be able to work on the care plan, and then gets the members of the team involved, especially maybe the doctors when the need arises. So Martha, I think I don't know if I've been able to do justice to that.
Not exactly. To some extent, yes. But the question I'm asking that, for instance, the record you're talking about, can you hear me? The record we're talking about here, the record is like a document. It's like a paper, like a document, right? So in that document, who keeps the document? Is it the registered nurse that keeps the document, or you as a caregiver or a CNA?
Okay.
Now, what I'm asking is because you talked about, you talked about signing, that when you document, it should be signed in case of anything. Do you understand?
Yes,
so
yes.
Is it that I will have a record for myself? Now, let me give you an example. Let me tell you why I'm asking this question.
Okay.
I'm an ex-banker. I'm an ex-banker. And then and there was a time where we gave a loan to someone and the person defaulted. And now that loan was actually not a good loan because there was somebody behind it that didn't want the loan to be paid. The person actually took the loan from the bank through someone with the hope of defrauding, as in not paying back. So because I kept my own record, because I was just sensitive enough to keep my record. In fact, I took the record, I made photocopies, and I took them to my house. So when there was an issue and we had to now try to dig the whole thing, the file got missing from the office. When there was a serious issue, the file got missing from the office because the person that was behind it was a staff. So now, what exonerated me, what really helped me was because I brought my own file where everybody signed it. That's why I'm asking that you were talking about if there's an issue, for instance, if you don't report it. So who keeps the record? Is it the registered nurse who will sign it? Is this something that the registered nurse write it down, then I will sign that, yes, I brought it up. You understand what I'm saying?
Yes, Martha, yes. I see why you are asking that question, because I was just wondering why. Now, this is what happens. In any of such things, as even you, as you are the certified nurse assistant, you have your own records. You have your own record. But it is important to note that if you do anything wrong, that is, I don't know how to explain it, that's if you don't do anything correct in the line of the care, the nurse, the registered nurse herself is held responsible. You have your own records. And when you write your own, you sign, because there's nothing you write that you document that you don't sign. Signing seals it. That signing tells someone that, yes, you actually are privy to what is written there. So you sign. And when it is signed, the nurse is the one that keeps you can have your record if you like, maybe your personal record, like we have our jotters to write whatever we have. But at the end of the day, the nurse incorporates all those things that you have written there that has been signed. You understand me? But the record is your own. Like you are the one that has the record. You are the one how do I put it? Oh, you are the one that signed the record. So it's binding on you. But it is the nurse, because the nurse has to have to be with those records in order to incorporate it to whatever thing she wants to come up with at the end of the day, maybe changing the care plan or doing any other thing. So it's a two-way thing. I understand why you're asking that question. I know what you want to say. That's if there's any issue, maybe the file gets missing, like it happens, or the nurse says she didn't show me, or I wasn't aware, all these things happen. So at the end of the day, you have signed.
Exactly.
I understand why you are asking. You have your own record, but the thing is, your record without the nurse going through and appending her signature is not a record, because it's assumed that the nurse does not know about it. So that is just it. I don't know if that's okay. Patience, Gold. I can see your hand up. Okay, Patience.
Yeah, so
yes,
to what the question that she asked, I'm just thinking, and I have running imagination on what it could look like. So for modern facilities, for instance, and I mean, it could be a factor of the role you are playing at any point in time for you to say you want to keep your own record. Take for instance, if you are mounting the very first point of call, maybe taking vitals, and you want to, and most of them are these days computerized. Even here in Nigeria, talk more of abroad. So they want you to enter into a system. You discover that each facility will have accounts, right? You are logging into your own account. Maybe if another person is taking over, is that person's account. So every detail that is recorded, there is already. So I'm just trying to say that the facility already have like a place where you put in records. If it is something that is recorded on maybe like files, like we used to do in those days, when doctors are doing ward rounds and maybe you are following, you will see them writing things on paper. If it's that kind, I'm just wondering if it will not be a case of, in the light of the question she's asking, duplicating that record because you want to keep, you want to ensure that you keep what you have recorded. Won't there be some level of infraction on privacy, confidentiality? Because unless if the facility allows you to actually keep your own record, I don't know. But I feel that they will have a provision for how they want you to relay whatever information that you are taking, to relay it back to the nurse. I don't know that it is verbal. It must be something they are provided, whether it's something where you write, which your handwriting is there, or it is something you enter into, details you enter into.
That's
I'm just saying that there must be a system already existing that entails that. So if you're not saying you want to keep your own or keep a copy of your own for this kind, wouldn't that be an infraction on confidentiality, or you are keeping if they don't permit it?
Okay, now it's important that at this point I have to say, okay, thank you so much for that explanation. So I get what she's trying to say, like the Matter Act. Now, just as it is, now if we look at the analog and the digital settings, thank you for bringing in the digital, because now in the digitalized world, just as you have said, there are many ways that you can impute information. It could equally even be sent via mail. It's just like I sent your forms to you via mail, and it will show me that it's received, to show you. So even when the person does not receive it, if there is any challenge, already the mail can prove. We have it can prove that the person has actually received it. So every facility, like I said, not only a hospital, even if it's care facilities, it's care homes, they have their procedures as how to go about things. That's the first thing I want. They have their procedures of how to go about things. But the most important thing that I want us to know is that a certified nurse aligns with a nurse. You may decide to have, it's not any infringement, you may decide to maybe have your own, maybe this is what happened, you just jot your own maybe to have. But there is a template, maybe that's what I should have said. There is a template that is already there, depending on the hospital, depending on where the nurse has to impute. I mean, the CNA imputes whatever is her own document, like to document it. The nurse to follow up. What did you do? For instance, maybe if a CNA says that while taking care of my patients, I saw bruises, all over the body, redness, and maybe she tells the nurse verbally, she would have to document it. Especially if it is during her shift, she have to document that. So with Mr. So while doing this, I saw this. I should have, okay, maybe I'll drop it on the group, a sample of that template, so you better understand what I'm trying to say. So the nurse will write, the certified nurse will write, the nurse will write, if it is a written one, if it is entering into the computer, those documents have to be there. Why? Because it can be called back, it can be called upon at any time. It helps as a follow-up. Anybody, maybe even if a new doctor sent to that place, or a person that comes around for checks, to follow and check whether you are going aligning with the ethical principles and everything you need. It is very easy to reach out and get information. So it's like a continuity. They get to see how this person was when the person came. Okay, these are the things they observed. Having observed this, the nurse was able to do this and do this, and the doctors were called to handle, or maybe to attend or to assess the casualty. Even sometimes a therapist is even involved, so that they find out if it's as a result of maybe suicidal ideations, or maybe the person inflicting the wounds on himself or herself. So it depends on the care facility, depends on what they want. But the fact remains that it is a record that, especially a certified nurse assistant's own, at the end of the day, it's a record that it is there with the nurse, because the nurse is your immediate boss. The nurse is your immediate boss. Who is this document? Each duty you are documenting, because you don't document it. Duty will be blamed. That's why you're on duty anytime. Thank you so much. So that's what I'm trying to say. Because even when you leave duty, another person can come to assume duty. So I don't know if there's any other question for us so that we can move. We still have end of life care. Is there any other two hands raised? Were they the former hands or the present hands? Okay, can we go at Mr. Isaac? You wanted to say something. Okay, please do so that we can move. Please do. Thank you, sir.
I want to say something pertaining to what our sister Martha was trying to ask about documentation. You see, there was a time ago, someone told me this, that they took a patient who was about to deliver, right? Now, yes, in the delivery room, I don't know, you know, there are points of time where these children, if the baby is not trying to come, I don't know if they can give a certain injection to give force or pressure for the baby to come out. I hope you are getting me.
With you, I'm hearing you. Go ahead, sir. I'm hearing you.
Okay, so one of the midwifery went and gave an injection to this woman, and that injection was not what she was supposed to give. So this pregnant woman started misbehaving, funny way, a very funny way. So a senior midwifery came in the room, and she said, "But what kind of medicine did you inject?" And she showed the medicine. And she said, "No, this is not what you were supposed to give to this lady here." You see, unfortunately, this woman was called for ambulance, and on their way to a bigger hospital, she passed on. Okay, now the family was wondering. The family was wondering, how come our wife or our sister just passed on like that, because she was okay. And nobody could tell the authority that this is what exactly happened. They were keeping the news or whatever happened in the room, in the delivery room. But fortunately for the family, there was a patient there who was recording their voice, okay, who recorded their voice. So after some days of mourning, she went to the family and said, "No, there is something I want to tell you people. This is what I overheard the two midwifery discussing concerning your patient who passed on." And she played the audio to them. You see, and when she played the audio, and after listening to the audio, they realized that it was the midwife who has really killed, and they were taken to court. Okay, now if I can understand our sister Martha, she gave an example at the bank. Now, as a CNA, if you keep your documents and the nurse, for instance, there is in your care, you have lost a patient, and the nurse, after you reporting to the registered nurse, then there is a case at the hospital like that, and she said, "Okay, in fact, you did not report anything to me, and I don't have any care plan concerning that patient we have just lost," whereby you, the CNA, acted well by reporting whatsoever you saw on that patient to her, and she is denying. Now, what in such case, what should you do? Will the authority accept your report that you recorded and kept, or they will not listen to you because you don't have all the authority as the registered nurse have? Would they accept your report? I hope you are getting me.
Cracking, but I hope I understood you. Now, what you are saying is, who actually gave the injection that killed the woman? Because I was trying to, my network is a bit, who gave the injection?
It it was one of the midwifery on duty.
Midwives, okay.
Yeah, one of the midwives.
Okay, so this issue, was there any certified nurse assistants in their midst? Or it was they were all midwives, all of them?
All of them were midwives. But I believe one is a senior. Okay, so the senior told the other one, this is not what you're supposed to give to this lady.
Okay, I get you. Okay, Mr. Isaac, now that's why we have how do I put it? There are so many anomalies in the health, in the medical profession. There are so many anomalies. Just as you have said, first and foremost, the nurse that gave that medicine, that midwife, was she supposed to actually be the one to administer that medication to the midwife? That's very important. Because like I like to say, that when we are dealing with human life, we cannot gamble with a human being's life. We can't gamble like just to say, let's do what we feel like to do. No, we cannot gamble. So if in this case, that's why I asked you if a certified nurse assistant was involved. I thought you said it was a certified nurse assistant that was asked to give it injection. I would have said that first and foremost, it is wrong for a certified nurse to be the one to give the injection. But since you said they are midwives, then they're supposed to know. They laid down procedures as to how before you actually give an injection. You don't just give injection because you feel like giving. No. It's just a clear thing. Is you moving the doctor diagnosis. It's not even the doctor in most of the setting diagnosis. Okay, this is it. Check, do this test, do that test, check vital signs. At the end, you collate it, you give. You can't just on your own decide to give any injection. And there are ethical implications regards that. There are ethical and legal implications when you go that way to do this, something that can even cost two of them their license as nurses, since they are not certified nurse assistants. It will cost them their licenses, because it's not about I told you to do this, I did not tell you to do this. Verbal things, I can decide to say something on this platform tomorrow, I say I did not say it, for instance, now, because it's not binding on me. But anything that is documented, anything that follows the norms, anything that maybe someone has, like a doctor will write, okay, give so amount of this, and sign over to now to follow it up from there. Whatever happens, they care, those people that are involved based on the documentation, both the doctor, whether maybe that prescribed the drug, that asks the nurse to follow up and give so drug. At the end of the day, they are all in for soup. They are really in for soup because they don't follow ethics. That's why we talked about ethics and professionalism. You cannot just guess. Maybe that one that actually killed the woman just guessed that, okay, as she is like this, oh, let's just induce her, let's give her this, especially when it comes to the issues of delivery. So many things can go wrong. So many things can, with midwives, they can just bring up so many things. Like I try to advise people that most people that go to maybe homes around, they say midwives, they want to deliver there, they have 2 or 3. This one can say, oh, the labor is too hard, let's give soap. This one can say, okay, let's give this. This one can say, let's get. At the end of the day, those people. But at the same time, since it's not a hospital setting, even if they blame them, the first blame will be, why didn't you go to the hospital? We have professionals. And where we have these professionals, do they actually follow the ethics and go about doing things in the proper way they're supposed to do? That is where the question is. So when it gets to the legal terms, I'm not actually a legal luminary, but what I know is that we have to ensure that we follow the ethics, follow what is documented, because anything that is documented is binding. If the doctor had written, okay, over to the nurse, this is what you're supposed to, this is how to attend to this pregnant person, this is what to do, she has to take this, induce her, or be there while in labor. Good. They are all parties involved in the crime, partners in crime. So that's it, Mr. Isaac. Our hands are raised. What's our time? Okay. I like to take questions, so because I don't want anybody going without, okay, 7:21. That means we will exceed the time. All right, this Xiaomi 230-28R. I don't know who that is. Please, who is using that Xiaomi 230?
Hello, can you hear me?
Okay, Martha.
Yes,
Martha, please go ahead. I've not heard your voice since you came today. I think I've been hearing the other.
Yes.
Go ahead.
Good evening.
Go ahead. Good evening, Martha. Welcome.
Thank you. I just want to say something concerning the question the other matter raised.
Okay, go ahead. Say, that's why we have knowledgeable professionals. Go ahead.
a CNA position in any care organization or in the hospital, there is always a rule for documentation.
Correct.
Because nurses are there, caregivers are there, CNA are there. They put it on notice. If it is
templates, yeah, templates. Go ahead.
Money duty you are, anything you see on that patient's body or any mark or any sign you see, you document it.
Document, report, document. Go ahead.
Duty if it is on night duty, and the first person on duty did not document it, they will hold the person in the night shift because something like that, you did not document it or you did not report immediately. My sister in UK said the same thing. They always have these issues. So she always remember to document any information or any sign, anything she noticed. She put it down so that they will not hold her responsible for it. It's always documented. If you are on morning duty, you document your own. If you are on afternoon duty, you document your own. At night duty, you document your own. That is how it is. You should not forget documentation is because it's very, very important.
Thank you so much, Martha. That's to buttress what I already talked about. I cannot overemphasize that. That documentation is very important in anything you do as a certified nurse assistant. My only talk is that as a certified nurse assistant, your power is limited in some aspect. But you report, and you report directly to the registered nurse. You report directly. You cannot say because you've documented, you take your document straight to the doctor that this is what I saw the wound, or to the maybe, no. You have to. You cannot jump the ladders. You have to, and especially where you have shifts, just as you try to say, Martha, where you have shifts, where you have someone come in the morning and then the person go in the evening. Most times in the long-term homes, some places that we don't really have much of this shift method, but especially where you have the shift method, where you have this nurse resume, the other nurse take over, another one takes over, you have to document so that when you document and you hand over, it's also handing over. So you hand over to the next nurse. That is why when another nurse comes to take over from you, you see them, if you are in the hospital, you see them move around to do checks. They will come and see the patients. They'll open the door, move around to see you. Oh, how are you? Okay, what's the issue with this patient? They'll write it. Do you understand? So that at the end of the day, everything is documented properly. Documentation is very important. So I don't know if we are done. I'm still seeing Esther. Esther, are you raising your hand again, or it's the first one you raised? Esther or Chepa?
Yes, I'm still raising my hand. Okay, it's still in the light of matters.
Because I saw your hand.
I just want to, yeah, if I got the whole scenario right, like what the other guy also, the scenario of the midwife that he talked about, I think he's only just painting a picture of what happened in that in the hospital.
Yes,
but bringing it back to our own home here, bringing it back to our own home, we're talking about the CNA. Now, he is trying to see who takes the blame, because from what I understand from everything that we've been talking so far, I can say who bears the negligence, who bears once if there's a lapse somewhere. Like if there's a registered, if the CNA had done her own part, and probably there's a negligence in the part of the nurse, who bears it? Who bears the consequence?
Exactly.
Who takes the blame? That is what I think the whole thing is all about.
Okay, let me throw more light in that. Now, if the CNA has done her part, and because the CNA has done her part and she has documented, see, there are things the CNA cannot do that originally is the nurse's duty. So if there is any lapses or any fault in the part of the nurse, it is absolutely the nurse. Even if there is a fault in the part of the CNA that is attached to a particular nurse, because each certified nurse assistant, how they do it, you are attached to a nurse. If you are coming shift and meeting another nurse, you should know that, okay, this is my immediate, I have to report anything that goes on within that shift, if it's the shift method. So if there are times, even when a CNA goes wrong, because it is the nurse that gives instruction to the CNA, it's the nurse that directs the CNA as to what to do. So if there is lapses, if there is fault on behalf, lapses in the duties of the CNA, the nurse, that's why I said it in the course of this training, I said it earlier, that the nurse is held 3/4 to blame for anything, any obstruction or anything that is not done well in her. It's just like a supervisor being held responsible for the actions of the teacher. The supervisor will blame the teacher. Why didn't you do this? Why didn't you do that? But when the Minister of Education comes, it is the office that they meet. It is the supervisor, it is the nurse that is held responsible. And you see, most times the nurse will now try to come and see how to transfer it to the junior person. But that's just how it is. So if a CNA does something wrong, she is also, I pray none of us do that on this platform, she's also responsible. But to a greater extent, the nurse that she's supposed to be reporting with to, that gives her the instruction, that gave her the care plan, that is in charge that particular time, is held responsible, because it's assumed that you did not oversee, you didn't do your duty judiciously. If you did, there wouldn't have been lapses on the part of this CNA. And even if it's the nurse that makes that mistake, she, the nurse herself, is held responsible, because she's supposed to know what to do in that hierarchy of authority. So I think I've been able to answer that, Madam Esther. Is that clear enough? Okay, no one is hearing me again. Is it network? Are we
No,
together?
we are hearing you. We are hearing you.
We heard you.
Yeah, we are here.
Okay, so Esther, you asked a question. Is that all for? Is that okay? Okay, maybe we've lost her.
Yes.
I cannot hear
No.
anymore.
Yeah, I said
Okay,
it's fine. It's fine because it's been
okay,
explained,
all right.
because everybody is just going
hear
around
you.
the same thing. That's why I tried to just point out
Okay,
the
okay,
fact
then I
that,
didn't understand. I understood it separately. Do you see where communication breach is communication is very effective? Because I didn't understand it like that. I would have answered it long ahead. Okay, thank you. So let's go to the last one. Quickly, we'll just wrap this up, and it's end of life care. Now, what is end of life care? Most times, like I said, CNAs, caregivers in anywhere you are, and then nurses, people that work with these vulnerable people, they get to a point in time whereby you have to see them really deteriorate or maybe end their life, towards the ends of their lives. So you know how such situations can be. You understand? So end of life care is simply when someone is almost moving, when the person has just, maybe the person has been diagnosed of a terminal illness and the person has been told, okay, you just have some days to go, you have some hours to go or some months to go. And the person knows, because of course they'll tell them in some of the cases. In most of the cases, they let them know. So what do you do as a certified nurse assistant? All you need to do is to try as much as possible. Just as we know, most of those people prefer the end of life care in their homes as much as possible. People that I know, maybe that have really been diagnosed, they have some months to go, they have some weeks to go. What they do is to try to spend their last days in their homes. They like to. That is actually some of their wishes. You know, they don't want to be in a hospital. Why? Because they feel, let me be in my house where I'll be surrounded by my loved ones, where I can see them, you know, I can relate with them and end my life happily. That is very, very important. So that is end of life care. So end of life care can be in different settings. It can equally be in the house, in the homes of people, you know, where they stay and look at counts to their last days when they will eventually go. You know, it could be in the hospital, it could be in the hospital setting as well. So as certified nurse assistants, you may have these people that are actually in the end of their lives, And so what is your duty as a certified nurse assistant? You have a big role to play there. You have a role to play. These people, most times they have they pass through a lot, the physical pains. They have the physical pains, maybe pains in their body, not being able to sleep, or extreme discomfort. Sometimes it gets to that point where they are extremely uncomfortable. You know, there is nothing as huge. Just play it in your mind. There's nothing like
okay. End of life.
Being aware that
Life.
you have calmed down. Oh, so somebody is just aware that I don't have long to stay again. Already it is demoralizing. Already it's not something you wish your worst enemy. You know, so certified nurse assistants, it is your duty to give them, to observe their approach. There are things that are going to happen as they approach their last days. So what can you do is to show them love. Except touching, just a gentle touch, to let them know that it's going to be okay, you know, to give them a shoulder to lean on, to offer them that emotional support that they really need. Since you cannot treat them medically, because it's not about helping them to, you know, giving them for the curative aspect of it, like curing them of their ailments. No, it has already been diagnosed that they don't. Sorry, I think this is the first time network is actually playing a fast one. Just bear with me a little. All right. Sorry, let me. Okay, so fine. Are we together? Can we see my screen? We had a network fluctuation. Can we see? I've almost come to the end. Network, please, I'm begging. I don't understand. See me, please. I just need the response. So please, can everyone see the screen?
Yes, I can see it.
You can see the screen.
So now we will.
She sounds tired now.
The screen went blank.
But she don't get patient. Answering everything. No rushing anywhere. She really be.
Please, so I don't know what is doing this. We have come to the end. Oh, please just allow us to get it over with. Okay. It went off and then back again. All right. Let's see the screen pop up for everyone. Okay, thank you, because I don't know what actually happened. So we're talking about end of life. Some of us that have had parents, we've had maybe relatives, relations, or we've been working, and then we've had people that are actually in the end of their lives. You can understand what we are trying to talk about. There used to be the psychological effect of that, even with you, the person, the family member. So as a caregiver, you have to carry everybody along. You have to ensure, as a fine nurse assistant in the hospital setting, you have to ensure that you give them, like you can see that picture, it depends on the one that you can hold, but you just give them, let them know that you are there. Let them just know that you understand the situation. Let them just know that, well, you know, the next slide. And see, you understand the dying process. It's not easy to tell someone to understand the dying process, but you have to understand it because of, by virtue of the fact that you are in the health sector, you deal with these vulnerable people and you will see it. There's no how. I remember some years ago, I had a friend, before I actually delved into this healthcare, someone, maybe you were taking care of someone, or she's actually a nurse by profession. So she tells me, I observed that the way she takes these things on the surface. So I was like, how do you even cope? Maybe you have to treat someone and every day you see the person degenerate. Maybe you see the person emaciating. You see that it's as if they're just pouring water into a basket. The person is not getting well. So what do you do at the end of the day? She just smiled. She said, you just have nothing to do than to
Next up, Ma, you are muted though if you are talking. Because it contains
okay. Okay, so let me hurriedly round it up because I think network is getting bad towards this end. This is just the last slide, or there. I think we have 1-2 slides to go. So sorry about that. Network has been so nice with us. Just now, it's just there to do whatever. So providing comforting measures and techniques, such as, so the things you can do is maybe if it's in a hospice care department or where you work, you are dealing with these people, this end of life people that are getting close to going, you can provide them with comforting measures. Maybe you can reposition them if need be, ensure they have a peaceful environment. That is very important. Those people, on no account should we even try to maybe joke with them for any reason, like you have to ensure that whatever you can do to ensure that they end the process, they have a seamless process to end it, happy process, having lovely memories. There are things that you need to do. You can decide to keep them company. Most times, those people, they may, depends on the individual. Like I said, we are all different people, individual differences. So there are some people that would like to have maybe you around them. They just want you to keep them company. They just want you to be there when they play music, you know, just to lean on you, or maybe to be sure that someone is there, you know, to help them pass through the process. You can do that. Also, you allow them to express their fears. There are people that normally they don't like to talk about it, but there are also people that want to talk about it, you know. They have memories, they can express their fears and concerns. Oh, this one that I'm going to go, who is going to take care of my child, or who is going to do this, or who is going to do that, you understand? So their fears, they can want to talk to you. They can just want to pour out their minds to you, concerns about dying to you, and even to their family members, to be willing to hear about their lives. Some of them have already reached the stage whereby they have come to terms with the fact that they don't have long to live. So there are different stages. They are the ones that even as they are there, they are still hoping, holding on to a miracle that something will happen that they are not going to end it good. Then there are some that already have come to terms with that fact. Like they have just said, it's part of life. There's nothing I know I'm going to live. Let me make the best of this remaining few period that I am. So those people can try to think, to talk about, they may wish to talk about their lives, what they used to do. If they were maybe very good teachers, if they were footballers, if they were anything, they could try to reminiscence, like try to recap their lives, the things that they were actually doing, you know, to highlight their strengths, like to thank God for giving them the opportunity for having done those things, and so on and so forth. So they may need to do a lot of talking to you. So what do you do at that point? You just give them that conducive environment, give them that shoulder to lean on, let them express themselves, let them talk about their strengths, let them talk about their fears, let them discuss anything they want to discuss with you. It is very, very important that you as a certified nurse assistant, you take note of that. You should not compound the issue by bringing things that are not unethical into the practice. Just show them that love, give them that emotional footing, you know, that they need to move ahead. You know, originally everybody has the fear over death. We have fear, you know, over death, and we grieve or we change. There are changes that happen in your body automatically if you are aware that you are going to go. So there are some changes that are conscious, there are some that are unconscious, and there is that fear for people to talk about death. So if they need to express their fears of how they are going to die or of what they are going to, and most times these people have interface with their families. Like I want to say, you as the closest person to the patients, you have to ensure that you can even interface, help them have to make that process seamless for the person that is actually dying, because sometimes they can come to the family can come maybe in the hospital if it is in a hospital setting, or they can be in the house, maybe in a specialized setting where in the home of the person, you know. So you as a CNA, you can help. You can even give a shoulder to the family to lean on. You can help talk to them. You can make them know that it's not futile, that life can still go on. The people they left behind, you understand? Because it's always a very, very emotional moment. In fact, it's a moment that nobody would like to see, maybe would like to experience. And you also take notes when you are doing these things. There are some that have cultural implications to them. There are some people that like to do some things when they are actually moving towards. So the family members could decide to maybe bring them flowers. If there are those that love flowers, they could bring them cards. Some could decide to say, oh, maybe bring them their grandchildren. If it's for the elderly that have children, could make them be around the things that they actually love. So even if it is not in their home, it is in the hospital setting, you can, with the help of the nurse and with the help of, depending on the policy, like I like to say, that different places have their different policies. So if it's a policy that accepts that, then that's something that you could, you know, do, aligning with the policy to help the families to have time, quiet time with them. Some may wish to say their last wishes. Some may have even said some things. That's the legal aspect of it that is not supposed to be handled by you anyway, the certified nurse assistant. They may decide to say, okay, when I eventually pass on, this is what I want to happen. You know, even before then, they may even want to have an interface. Those that have been reluctant, that will not want to maybe make their will or do anything because they are very, very holding on to the thread of life, that yes, I've seen, they have said this, but I know that I'm not just going to go like that. I'm not just going to pass on like that. So, you know, but when it gets to certain points, they will begin to come face to face, brace up themselves, and they would like to do certain things. So if it's something that needs privacy, you know, you have to give them a form of privacy as a finance assistant. Let them be with their families at least those moments, you understand? And maybe when they may even want to pass on or something like that, you may be the one right there, you understand? But in such cases, the nurse is always there, because it's something that is not always there, but maybe there. Let me not say always. So in such situations, it is important that you know what to do. There's actually what they call, our last 2 slides, is actually what they call hospice care, but we'll get to that. Be sure to respect their desire for privacy, like I already said. Work with the family in creating a caring environment and a beautiful environment that they will keep remembering. Document and report the person's passing according to the facilities protocols. Like I was trying to say, maybe you are the one there. So ensure that you document the person's passing when the person actually breathed the last, you know, and other things. You have to document it depending on your facilities protocols. That's what I'm saying. That's why I started the first day or so when we're talking of responsibilities. I told you that you should understand the place you work and know what they're, depending on what they believe in. So it's to align with that. You just have to align with that. Respect the patient's cultural, religious, or spiritual beliefs and practices. This is important. Some people have their own, depending on their religion, they have a whole lot of things that you get to see at the dying minutes when they want to pass on. They do a lot of things. So you respect it and you take it into consideration. They may need a pastor to come around to pray for them. You have to be accommodating. Don't say, no, we cannot. This is, especially if you have taken due a process, like you have consulted with the nurse and it's fine. Give them privacy. Let them do the prayer. Let them end it well. Let them remember the moments and all those things that are very, very important. So finally, like we want to talk about hospice care. There's something hospice, like we can see here, is a specialized type of healthcare focused on providing comfort and support now and pain management for individuals who are terminally ill. At that time, it's no more about the curative aspect of it. Let us cure, no. Because if it has been proven that the person doesn't have long to live, so the best thing for you to do is to move away from the curative aspect and try as much as possible to ensure that the person spends the last days happily. That is it. So what's the goal? Is to improve the quality of life for the patients and their family during that final stages of the terminal illness. It may not be, it may be old age, it may be terminal illness that has come with old age that is already been diagnosed and concluded that, well, except for God, because nothing is beyond him. But ordinarily, we have seen that there's no way out that this person is going. So it could be in the patient's home, like we talked about, it could be in the facility. So that's hospice care. It's a specialized type of healthcare that is focused on giving comfort, giving support, managing the pain, helping this person to, as much as possible, to see how to make that transition seamless for the person. That's hospice. So, and then finally, like I like to say, we have, after the hospice, we have the palliative care too. Now, there's a difference between the two. The hospice, like I said, is for people that have countdown. They don't have too long to stay. But the palliative care is a broader approach to medical care. It's broader, that focuses on relieving the symptoms of pain, stress associated with chronic illnesses. Now, these people, unlike the other one, they've not been how do I put it? They've not been diagnosed to be sure of having some time to go. They've not been diagnosed of having some time to go. You understand, like some months or so, but they're actually having one illness or chronic illness or the other. So the normal medical care there, the curative aspect comes into play. You know, they will give them the necessary drugs, try to hope and believe that they will do better, try to see how to help them to move, to be able to get better, help them their physical, their emotional needs, their spiritual needs, help to see that everything is channeled towards making them better. So there is a difference between the two. It is important. This is about the last slide for the evening that we are going to look at. But like I like to do, so that you will understand, because it's important for CNAs to understand the difference between the hospice and the palliative, because you would take a professional exam. So I'm not trying to give you expo here, but of course it doesn't over the years and from my experience, you cannot run away from this. So practically, I want to explain, because some people may not have understood what I'm trying to say. Now, let's take, for instance, like I like to give an illustration. Imagine that you have a patient that is named Sarah, you know, that is diagnosed with maybe stage 3 lung cancer. Maybe is having stage 3 lung cancer. She's still receiving chemotherapy and radiation treatment. She's still being treated to try to cure the cancer. However, she's experiencing severe pain and fatigue from the treatments. So in this case, Sarah's oncologist refers her to a palliative care team to help manage her symptoms. Do you see now? They have not told her that she will soon leave. They have not diagnosed and said that, yes, that she will not be able to go. So, I mean, that she will not be able to make it. No. So they try to ensure that she has the support that she needs. They try to give the curative treatment. So you see that that is palliative care. When someone is having a terminal sickness, he's still being cured, he's still having chemotherapy, he's still having radiation, he's still having all those things to help the person to be better. But in the case of hospice now, let's say Sarah, maybe this particular Sarah, her cancer progresses and her doctors determine that she has 4 months or less to live. The idea is about the duration of time to live. The idea is about we cannot do anything anymore. The idea is about helping this person to have a smooth transition. That is That is the hospice. So now let's say Sarah's cancer progresses and her doctors determine that she has a little time to live. At this point, Sarah's focus now will now shift from comfort, from them giving her comfort and quality, from curative treatments, I beg your pardon, to giving her the comfort and quality of life. Because now she has been told that all these things we have done is to no avail. And you have this time to stay. So as much as possible, this is when they now try to refer to hospice, the hospice nurses. We have specialists in that area. We have people that even if you are a CNA, you can be attached to the hospice care department. So you already know that you are dealing with people that have, so you have to attach extra emotions, extra attention to them, and as much as possible, take care of the family and help that process to be seamless. That is one of the major things. So that is the difference. So at the point that this Sarah, after doing all these things, she's told she doesn't have long to live. The next thing is to shift the focus from curing her, chemotherapy, doing all those things, to making sure she's comfortable and she has the best quality of life and a beautiful transition. That is just it. So when it is determined like that, the doctors will say she should be moved from this palliative care center to the hospice care so that they can give her all the love, show her all the love and attention she needs before she eventually passes out. Another example, which is the last, is let's look at another patient. Maybe John is in the early stages of Alzheimer's disease. We know how that thing is. He is still living independently, but his family is concerned about his cognitive function. Alzheimer's disease affects the cognitive function. And the stress is causing, and the stress that it is actually causing them. So the doctor may refer him to a palliative care team to help manage his symptoms and provide support for the family and plan for still palliative. But this particular John's Alzheimer's disease maybe progresses at that particular place. He's under palliative care and the condition degenerates. Now he has a prognosis of maybe 6 months or less to live. At this stage, he transitions to hospice care, where the focus now shifts to providing him with what? With comfort, to manage the pain, and to give him emotional support in his final months. So the idea is simply for you to know, just one word gives you strategically the difference. The palliative care aims to improve the quality of life, while the hospice care focuses solely on comfort and end-of-life care. So that being said, we have actually come to the end of all we have to do for today. I'm so happy we still have to, because I was saying when I look at the participant box, I'll see that maybe it's only 5 or 6 because people must have left me. So like I said, we have not hit 8 o'clock. So at this point, that is just the summary of it all. So as a CNA, you need to take note of all these things that are very important. But do not lose touch of the fact that the CNA deals directly with a nurse. You cannot place your hand on the nurse and do things, because over the years, there's been issues. There's been squabbles rather, between the nurses and the CNAs. You know, sometimes the CNA feels that they are not carried along. They feel that they are treated less of a human being. And you know, those kind of treatments, you know what I'm trying to say. So these are things that we must understand and know when to draw the line and know what our duties actually are, so that we don't feel somehow if indeed we are actually needed to carry out this duty. So I think we are done for today. Do we have any questions or any contributions? Are we even together? Has everyone heard me? I need to hear the voice of everybody, so I know that we have come together.
Yes.
Yeah.
That people do not leave their devices and go and sleep or go and do something else, because I've seen it all. There are times we have trainings, and then at the end like this, you say you see the number, but when you call on the people, some are sleeping and some have left their devices. And you know, mothers and fathers, since we are doing adult school, we have gone to kitchen to go and cook, and we'll tell our child, when you hear them say, Dad, let me know they are busy frying something. So that's why I want to hear from everybody, because it was unusually quiet. Please, are we together? Do we have any questions?
Yes, we are together. I have a question.
All right. Please go ahead and ask your question. Then
Yeah,
we'll take
my question
platform because our
is
time.
just simple, because when you open the slide of end of life, how do you manage your emotion? You as CNA, because my spirit just went down, like, because when I saw that nurse behind that patient, I felt so many things going on in my mind. Please throw more light on how to manage your emotion
when you are in the hospital?
Okay. Before I really answer that question, I want to tell you something. And that is, most of the things a CNA learns, that's behind the scene. Now I'm telling you people, everybody on this platform, most of the things that a CNA learns, as most professions, you learn on the job. What do I mean by that? For example, before I got married, I was told that marriage, my mother kept telling me, it's this, marriage, you just have to get married. I was thinking that when I marry, in fact, when I just enter my husband's house, everything is. But when I entered there, I saw that different strokes for different folks. I saw that when you get there, you are actually in the practical setting. That's when you know that, yes, theory is one, practical is another. So that's why I was doing that illustration. So as a CNA, there are many ways you can manage your emotions. You can do, like I said, you can, it depends on who you are. First and foremost, it starts from the person. Aside you being a CNA, what happens to you when you come face to face with such situations? Let's say maybe you are not in the healthcare setting. There are people that will cry. There are people that will break down. There are people that will show different types of things. But the bottom line is that we are all humans. Try as much as possible not to show too much of emotions when, don't allow your emotions have a better part of you doing the necessary things that you have to do while on the job. We are going to see, we have a couple of, I think tomorrow, if I'm not mistaken, we are going to get to see something in that regard. There are many ways, just as a person. Some people can do it by, just maybe stepping out at that moment. When you know that you are bottled out, you can step out at the nick of that moment so that you don't worsen the situation. There are people that won't be able to hold it because, of course, you can break down, just as you have told me. If it happens and you see someone that you take care of, that is emotional, that is caregivers burnout or CNA burnout. So we have to do a lot of exercises. We have to learn how to be able to handle our own emotions, depending on who we are. Of those tips tomorrow, God willing, depending, maybe that's what I will introduce to help because of this, what you have just asked now, because there are a whole lot of things that you can do to help to hold your emotions when you come face to face with these things, because of course the emotions are there, but with time, you'll be able to handle them. With time, you'll be able to handle them. Because it's just like a person that is giving a medical student that is asked to carry out the first test, maybe to dissect the human body and do, how it is. But with time, with practice, as time goes on, you will normalize and you do it. And people handle emotions separately. So, but the bottom line is that as much as possible, don't allow your emotions to overcrowd. That's to swallow what you should actually do at that point in time to alleviate the suffering and the pains of the people, of the immediate family that is actually passing through that a major challenge. So that is it. We have different ways of handling emotions. We have different ways. There are people that may decide to cry. There are people that will virtually cry. If they don't cry, you will not get the side of them. So there are different things that you can do. It's not something that you wish your worst enemy to actually see somebody die. I don't even wish my worst enemy. So that is practically it. Because of our time, there are a lot. There are about 15 tips. Maybe I'll drop it on the group that you can use to handle your emotions when you come face to face with that. I can see, I don't know whose hand is up. Mr. Wisdom. Mr. Wisdom.
Yes,
okay, you were talking.
Yes, I asked the question, yes.
Okay, because I saw the hand up. So never mind. Like, what I know how to do best. If there will be time tomorrow, because tomorrow we have 3 modules left. So we would have time. Would have a space of time to do that. We have about 15 tips to handle emotions when you come face to face with this. So I will try to do justice to that. If I don't drop it on the group, then tomorrow when we come, we would get that done because our time. Thank you so much. Any other question, please, before I hand over? Okay, so MJB Management and Integrated Services, we have come to the end of the training. Please, sorry, please, if you have any question, please drop it. I keep looking at that chat, like Martha and Eddie, drop any question. And again, it's important to note that do not interface with anybody outside the admin on the group. I must say it on this platform. we would not at any account be held responsible for any form of anything you do, a third party agreement or anything at all. It's important, I must say it, because I may not remember to drop it on the group. If there is anything you need to know that concerns MJB, that concerns BCC UK, we have about 4 or 5 admins on the group. Please reach out to them. Do not interface with anybody. The reason is that if anything that doesn't pass through us, we are not held responsible for it. We can only be accountable for anything that is in the line of is on our platform, and maybe we promise to do and we don't do. But any personal interaction with anybody outside the admins on the group, plead, please stay away from it, because this is a serious disclaimer. We would never be held responsible for any of the actions taken with a third party outside the admin. Thank you so much. And over to you, MJB management, please.
Oh, Doctor, thank you so much. Thank you so much for the wonderful lesson. Today has been a wonderful one. The network has been favorable. Thank you for what you've said concerning because scammers and fraudsters are all over. As you've told our participants, we are responsible for whatsoever we tell you. Anything that doesn't come from us, it is not from us. I want to thank our participants. It has been a wonderful time. I do want us to have a lovely night rest. I want us to rest. It has been a hectic day. I want us to have a lovely night rest. Good night, everybody. We'll meet again tomorrow.
Bye-bye. Have a lovely night rest.
Bye-bye.
Was that not okay for you? Yeah?
Sweethearts now. Oh,
you eat this and found right there.